بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. السلام عليكم. نرحب بكم جميعا. Welcome everybody in the second day of our 8th Saudi Pediatric Nephrology Conference. We will start in a minute, and today we will have 6 sessions, inshallah, and we will finish by 10 p.m. Dr. Khalid, تفضل.
I would like also to welcome our speakers, moderators, and all participants. Yesterday, the participants reached almost nearing 3,000 attendees. Hopefully today we'll reach the same number or more. Just a quick thing to tell that, please, if you have a question, put your question in the Q&A. Again, CME hours will be awarded to the target audience that's mentioned during registrations and those who's attending more than 80% of the 2 days. If you attended less than that, you will not be awarded the CME hours. No need to mention your name or your license number, whether in the chat or in Q&A. Q&A only for questions related to the lectures. The CME hours will be awarded to you electronically through the website of the Saudi Council of Health Specialties. So without more delays, so we'll ask our moderator and first speaker to the mics that are yours.
Dr. Ashraf.
نعم. السلام عليكم ورحمة الله وبركاته. I am Ashraf Mzayin, pediatric nephrologist at King Fahd University Hospital in Khobar. It's my great pleasure today to introduce Professor Abdullah Salum, a senior consultant pediatric nephrologist at King Saud University. Professor Abdullah Salum is a well-known figure in pediatric nephrology in the Kingdom of Saudi Arabia. During his long and rich career, Prof. Abdullah had a great contribution to the field of pediatric nephrology with many publications and by being one of the founders of the Pediatric Nephrology Fellowship Program in the Kingdom. Prof. Abdullah will talk with us today about lupus nephritis. Without further delay, welcome Dr. Abdullah. It's my honor and the mic is yours.
Thank you very much, Dr. Ashraf. It's my pleasure. In the beginning, I'd like to be sure that my voice is clear for you.
Absolutely, yes, it is.
Yes, because I'm sorry that my video is not working, so I will try to do my best. Thank you very much, Dr. Ashraf. Thank you, Professor Khalid Al-Sahran and Dr. Khalid Al-Hassan, أحبائي وأعزائي, for your invitation for presenting on a topic. Is very it's a painful life journey for a patient with lupus nephritis. I'd like first to mention some brief things about lupus nephritis, then we'll try to concentrate in the classical management and the novel management for lupus nephritis. Beginning, it is a very challenging disease for the nephrologist and rheumatologist. It's very aggressive disease, very progressive disease, and need aggressive treatment. And it is more aggressive in pediatric, in children, than adults. So what all the management mentioned, majority, in fact, it's implemented and for adults and modified for pediatric until now. What is the lupus nephritis? As we mentioned, it is a life-threatening illness, in fact, associated with significant complications. The disease is an immunological disease, and it's an autoantibodies attacking the self-antigens in the bodies, mainly by the B cells and some dysfunctions of the T cells. The ensuing immune complexes deposited in multiple organs in the body and lead to the dysfunction. It is very rare in young age group, less than 5 years, and peak around puberty. That's why some rheumatologists call it juvenile SLE. In fact, we do see a younger age group, less than 6 years. And the ratio, which is mentioned for adults between female to male ratio, 11 to 1, it is less here in pediatric age group, around 4 to 1. And the disease is very aggressive disease, and in pediatric differ than in adults, where we'll talk about the differences later on. It is more aggressive, and almost 3/4 of the patients will develop or involve the kidneys in the SLE, and we call it lupus nephritis. Among these 75%, around 30% to 40% progress to CKD5. How do they present those patients? Usually present with what we do see as nephrologists. We see the worst picture of the clinical presentation. We do see a patient who's presenting with nephrotic syndrome and hematuria, hypertension, renal failure. It's rarely that we do see patients with mild presentations. Unfortunately, this will affect the management and lead to or the need for more aggressive treatment for such children. The treatment available and most of the agents, it's designed for adult patients. In pediatric, it should be modified, in fact, because the presentation is more severe in pediatric age group. Comparing in this presentation, for example, hypertension, the initial presentation all over in all the classes is 14% versus 3% in adults. Proteinuria, almost 70% versus 44% in adults. The hematuria, almost 70% versus 25%. Cellular cast and others also more. And that's why it is very severe presentation in pediatric age group and need modification of the treatment, as we mentioned, and designed for children. The serology of lupus nephritis is essential. In fact, that, for example, it is anti-nuclear antibodies against, as we said, self-antigens like DNA, ROLA, SM, RMB, and antigens. But what is important for us as nephrologists is the antibody against ribosomal B, RMB antigen, which always indicate severe nephritis, the antibodies to RNB. The complements consumed in an inflammatory process of lupus nephritis, but the severity does not reflect the disease activity. What reflects the disease activity, not the serum complements, is the degradation of these complements in urine. The urinary complement degradation, activation of the C3 degradation and C4 correlate with the disease activity. And the disease is activated and the complement consumed through the classical pathway. That's why we do see the C1q and C4 more depressed than C3. Antiphospholipid antibodies, which is so common in adult patients, still there around 60 to 70% in children, but rarely we see thrombotic episodes in children. So just in brief about the immunological criteria, NH should be positive, anti-DNA should be positive, and other antigens, RNB, and others, and complements. In adults, they present also with maybe because of the interstitial nephritis associated either because of the disease or the medications with tubular disorders. This is rare in pediatric. Renal biopsy is very, very important, and it is mandatory, in fact, to diagnose lupus nephritis. And knowing the underlying histological lesion is important to decide the best therapy. The clinical picture should know that is sometimes not related to the severity of the histological diseases. It was reported many times, but not so frequent, even a negative serology in patients with a clinical representation of lupus nephritis clinically, and the biopsy show the so-called full house pattern immunological depositions. So biopsy mandatory, and even multiple biopsies needed because of either you modify medications or to look for transformations between the classes of the lupus. We do, in fact, multiple biopsies in certain situations, like, for example, if there is an improvement of the renal disease, but persistent of the nephrotic proteinuria, so we can modify the treatment to less aggressive treatment. And we do, if there is any persistent nephrotic syndrome or worsening of the renal function, we need to repeat the biopsy to use alternative agent or augment the dose of the agents which we are using. The pathology classification is mandatory and very helpful, in fact, for deciding which treatment. The pathological classification which we are using currently is based on the original WHO classification, which was developed in the 90s of the last century. The WHO classification with 5 or 6 classes, class 1 with normal glomeruli, and patient does not need intervention most of the time other than extrarenal manifestation can be treated with, for example, non-steroidal anti-inflammatory drugs and others. Class 2, when there is just mild proteinuria and sometimes it needs just a low dose of steroids. Class 3, divided in 2 things, in 2 parts, and one is with mild and the other is severe, which will be included in the class 4, which is the worst type, in fact. The diffuse proliferative glomerulonephritis. Those patients, by biopsy, they may present with necrotizing lesions, sclerosing lesions, and that type is the main presentation in our community here. And those patients, they do present with a severe presentation, need more aggressive treatment. Class 5, the diffuse membranous glomerulonephritis, and class 6, chronic sclerosis. And those patients, sometimes very advanced class 6, there is no treatment, unfortunately, and diffuse membranous can be treated. We will discuss about it later. The main class presenting in our community is a class 3 and 4, and about 65%. This is the new classification, and a classification of what they call it modified ISIN classifications based on the WHO classification, but they add and they will elaborate more on the activity and chronicity indices still used over the last 12 or 15 years. The staging now depends on this modified ISN classifications and emphasizing on the activity and chronicity indices to decide which treatment we should use for. So the outcome prediction depend on the pathological classifications, activity indices, and chronicity indices. This slide showing the stages which ISN use now. The immunofluorescence study is very essential for diagnosis and to see the depositions, okay, granular depositions. For better results, the sample should be processed in the same day if possible to have an more accurate results. So pathologists will tell you about the scoring of the activity indices and chronicity indices, and the scoring usually it's for example, the active lesions is out of 24 and the chronic lesions out of 12. This scoring will guide you to the decision of the treatment to be aggressive or not. Active lesions, very important to know the scoring because it is reversible. So may help for the prognosis. The serology, there is, in fact, differences in the renal survival among races. In our area, in Arab children, for example, they don't do well with the classical treatment. However, serology is the same and pathology is the same, but they don't respond. There is an element of genetic variation, which maybe modify the response to the treatment. The treatment, the 10 years survival, in fact, for over the last 50 years with treatment, there was a dramatic improvement after the introduction of the steroids and the cyclophosphamide. But this improvement almost become a plateau over the last 20 years in around 80% renal survival rate. Treatment for class 1, as we mentioned, no treatment and careful follow-up with the treatment of the extrarenal manifestations. The treatment of class 3, when there is a more than 40% of the glomeruli involved, should be more aggressive and should be included in the management of class 4. Class 4 is the challenging for the nephrologist. Those patients, as we mentioned earlier, they present with hypertension, nephrotic syndrome, progressive renal insufficiency. So the treatment is first is steroids, and the steroid should be used in high dose in the acute stage. It is not effective in the long-term run, but maybe good for the short, early presentation for the induction. Unfortunately, if you use it for long-term, this will affect the growth of the child. We should not forget, as we mentioned, that the treatment depends on the pathological class and the activity indices. The treatment for class 4 usually need an aggressive, as we said, treatment with high dose of steroids, intravenous methylprednisolone, 30 milligram per kilogram per day, or per dose over 4 hours. In fact, some studies mentioning that it is 10 milligram will be effective. Our personal experience showing that 10 milligram per kilogram is not effective, and 30 milligram showing a dramatic response. The second line of treatment is the cyclophosphamide, and it's the gold standard. In fact, the cyclophosphamide. It's used either parenteral or oral. There was a protocol in 90s, last century, for this aggressive type of lupus, the type 4, using the cyclophosphamide IV, 750 milligram per square meter for 16 doses. This exceeds the gonadal toxicity level. 16 doses on a monthly basis for 6 months, then every 3 months for completion of 3 years. We did a prospective study on that protocol, which was used and was popular in our center. And we showed, in fact, that this cyclophosphamide protocol is good for short period, but not effective in the long-term run. So if you can see in this table, the serum creatinine, initially we had almost 2 patients with renal failure. Then after 36, after completion of the treatment, that all of them almost in normal renal function, but after 2 years later, almost 4 patients out of 9 developed end-stage renal disease requiring dialysis. So in spite of this high dose, unfortunately, those patients did very bad at the end of the study, in spite of the gonadal toxicity and risk of malignancy and others with this mega dose of cyclophosphamide. So similar to our study, published many studies mentioning the same finding, then people tend to modify that protocol to use it for only 6 months and use a maintenance of MMF for either 2 to 3 years. This protocol is still, it is the standard almost now. And even the KDIGO, recommending it until now. The recommendation in 2012, using the IV cyclophosphamide or oral cyclophosphamide, and the last protocol published, or the guidelines published by KDIGO, unfortunately the same. There was no change other than just modifying or reducing the dose of steroids. Nothing mentioned about more important agents used and successfully these days. These are the biological agents, the rituximab and belimumab. Both are B-cell depleters in different actions. Rituximab is more popular, and belimumab used for resistant cases. So, in fact, I ran through many studies and personal communications all over the world regarding the rituximab-based protocols, which I think that it will be the drug of the coming decade for treating lupus nephritis. The protocol used for rituximab in 2 phases, one with normal renal function, and the other with abnormal renal function. The one with normal renal function, they use the same as what we did before, the IV pulse methylprednisolone for 30 milligram per kilogram per dose to put the patient in remission, and then to use the rituximab after that pulse, 375 milligram per square meter of surface area in 2 infusions in 2 weeks apart. Then monitor the CD19 after 2 weeks. If the CD19 more than 5%, you can give the third and fourth dose. Cotrimoxazole will be given as a prophylaxis for pneumocystis. The abnormal renal function, same induction by the high dose of pulse methylprednisolone for 3 days, then oral steroids, and using the rituximab of the 375 milligram per square meter in 4 doses, 2 weeks apart, plus cotrimoxazole. Preliminary reports from different centers in the world showing an excellent response with these 2 regimens, either with normal renal function or abnormal renal function. Then that was for the induction. About the maintenance mainly, majority of people are using MMF for 2 to 3 years. Some rheumatologists prefer the azathioprine. This is mainly, in fact, for the extrarenal manifestations. And some are using the cyclosporine. About the resistant cases, until 2019, some people are using combination of rituximab and MMF, or intravenous immunoglobulins or plasma exchange. Recently, case series and case reports mentioning the benefit of belimumab. Again, this is an B-cell depleter, monoclonal antibody. The FDA approved its use in SLE in children, belimumab, in 2019, and showing a very good response, these patients, to this agent. And there is a trial now using it as for the induction stage for proliferative lupus nephritis. So there is an very promising agents to be used other than the old agents with good results. What's popular now is the rituximab and belimumab, and in the horizon, we have some others. So this is the treatment currently, either IV cyclophosphamide for 6 months, then MMF, or using rituximab for 2 doses if there is a normal renal function, or 4 doses if there is abnormal renal function. This is for the proliferative type lupus nephritis. Poor outcome usually in type 4. So that's why we have to be, as we said, aggressive in treatment. And if there is a high scoring of the chronicity indices, and if there is a renal failure or present with severe nephrotic syndrome, steroid resistance. The end-stage renal disease in the old practice and old protocols is around the risk is around ranging between 18 to 50% according to some study reports. And some
Abdullah, أعتقد إن إحنا التايم الآن.
كم باقي؟
هو إذا على وقت بدايتنا إن باقي المفروض الآن نوقف حتى نأخذ الأسئلة. فإذا you have 1 minute مثلا.
طيب باقي يعطينا 1 minute لأن كانوا الشباب يتكلمون. طيب we should not forget that patients with renal failure can be reversed if we use the pulse therapy treatment and IV cyclophosphamide or rituximab. The dialysis can be exaggerating for the extrarenal manifestations, and transplantation, the outcome is excellent. It's to conclude just that treatment of lupus nephritis has been one of the success stories in nephrology until the 80s and 90s of the last century. Then it became plateau. The treatment for class 4 should be vigorous. And as we said, there's promising agents, monoclonal antibodies. Still, there is a question. There are still questions about the duration of our treatment, for how long we should continue. This is a statement in an old revision review article published in Saudi Kidney Disease and Transplantation. I wrote it. And until now, this question is not answered. No definite duration of treatment for lupus nephritis, and seems that it is a lifelong painful journey for the patients and families and physicians. Thank you very much.
Thank you very much, Professor Abdullah, for this, although concise but comprehensive and focusing on the most important aspects of management of lupus nephritis. We have a few questions here. First is asking, what's the minimal age which is allowed for rituximab according to the Saudi FDA?
What is the
minimal age allowed to give rituximab?
Okay, this is a very good question. Rituximab can be used in young age group. Even there is a report mentioning about the neonatal or congenital SLE. It was used. There is no limitations for age until now.
Excellent. The second question is about the mycophenolate. Is it suitable to be used as induction therapy rather than just maintenance?
Which agent?
The mycophenolate, the Celset, mycophenolate.
Okay. This is a very big question and controversies about MMF. MMF used in, especially in the United States, as a first-line treatment. Our experience and others showing that MMF is a weak drug for especially for proliferative type lupus nephritis as an induction agent to be used. Used somewhere, but it is not that much effective. People are directed toward the rituximab.
Okay, here's a question. What are the criteria for non-responders in stage 4? I mean, what I understand, maybe when you can say that this patient is not responding.
Okay, there is a criteria. The presence of proteinuria, okay, this is one, and the serology. If the ANA is still high and anti-DNA is still high, this is an indication that there is no response, and patient will need a biopsy, repeating biopsy to see or revise the class for that patient, and to use more or different agents or more potent agents for treatment. The presence of proteinuria, nephrotic syndrome, and of course, if there is a high creatinine with the serology.
Okay, there are many patients who are responding initially clinically and serologically, but later on during the follow-up, they will have a serological relapse with no clinical clear-cut relapse. The question, would we here upgrade or add agents based on just serological relapse, or we need a clinical relapse also?
Like these patients while they are in maintenance MMF, for example, or without treatment?
Yes, during maintenance MMF treatment.
And they are showing, serology are positive and clinically negative.
Initially negative, then with follow-up, the serology start to be again positive, but without clinical relapse.
Okay, this is very important. Some people are suggesting if there is a flare-up of the disease, that to use an IV pulse therapy. Okay, just to put them in complete serological remission, and then to continue in their maintenance MMF. Pulse therapy can be repeated many times, in fact, if there is a need to put the patient in remission.
Okay,
Of steroid, pulse therapy of steroids, sorry.
Yeah, thank you very much again, Professor Abdullah. There are many questions and there's active interactions, but we are at the end of our lecture. Thank you for the Prof. Abdullah and for the listeners, and thank you very much.
Thank you very much. Shukran. Sorry for this technical problems we have faced.
Thank you, Dr. Ashraf. Thank you, Prof. Abdullah. We will move to the second lecture. Dr. Ibrahim, if you can introduce yourself and the speaker.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Ibrahim Sandukji. I am a pediatric nephrologist from Al-Madina al-Munawwara. Ala sahibiha afdal as-salatu wa atammu at-taslim. I will start with thanking the organizing committee for allowing me to moderate this session. And I would like to congratulate the organizing committee for this successful conference with very large number of attendees, mashallah. And now it's time for an interesting and important lecture about rapidly progressive glomerulonephritis. Our speaker is Dr. Muhammad Samir Bafaqih, a pediatric nephrology consultant in King Saud Medical City in Riyadh. Dr. Muhammad has graduated from McMaster University in Canada, where he completed his pediatric nephrology fellowship. And before that, he has done the Arab and Saudi boards of pediatrics. Dr. Muhammad has participated in several national and international conferences and meetings. Without further ado, I would like to welcome Dr. Muhammad. Dr. Muhammad, the mic is yours.
Thank you very much, Dr. Ibrahim. And kindly let me know if my voice is so high or so low, so I can adjust it.
Your voice is excellent.
Okay, thank you. As announced in the symposium schedule, I will be talking about rapidly progressive glomerulonephritis. Through my talk, I will go along the way through introduction, mechanisms and differential diagnosis, clinical presentation, evaluation and diagnosis, and initial empirical treatment. And then I will present a case from my practice. Then I will give a take-home message at the end. So, from starting with the introduction. So, what is the definition of rapidly progressive glomerulonephritis? So, from the name, it's something happening quickly, and it is an inflammation of the kidney. But to go for a more scientific definition, we have the definition from the Japanese Society of Nephrology in their clinical practice guideline. They defined it as a syndrome that progresses rapidly within a few weeks or months to renal failure and is accompanied by urinary findings of nephritis. However, there are many other definitions, and KDIGO chose to define it more specifically and more objectively. So they define it as more or equal 50% decline in the eGFR over less than or equal 3 months. So this is shortly, but if we took it widely, it's composed of 3 components. So the first one is a rapid loss of renal function over a very short period, days, weeks, maybe a few months, but less than 3 months. And nephritic urinalysis, i.e. proteinuria, micro or macroscopic hematuria, dysmorphic red blood cells, and red blood cell casts. The third component is histological characteristic on renal biopsy finding cellular crescent formation in the glomeruli, which is proliferative cellular response seen outside the glomerular tuft within Bowman's capsule. And because of its crescentic shape, it was called crescentic glomerulonephritis. So we can see here on the right picture how a normal glomerulus appear. The other picture on the left, we can see how the crescent evolved the Bowman space, like this one, and this one, and this one. So historical wise, Volhard and Faher first made the observation that crescents were associated with a poor renal outcome. And in 1942, Ellis was the first to use the term rapidly progressive glomerulonephritis in describing the subset of patients with post-streptococcal nephritis who had a poor clinical outcome. In 1962, Stibley described crescentic glomerulonephritis in sheep induced to make anti-glomerular basement membrane antibodies by immunization with heterologous glomerular basement membrane. So what are the mechanisms of renal injury in such a phenomena? So it's usually due to one of three. The first one is due to a direct antibody attack, like happening in anti-glomerular basement membrane, a disease when the antibody is attacking the glomerular basement membrane directly. Many such patients will have pulmonary involvement due to cross-reaction of the antibodies with membrane components of the pulmonary capillaries. And the second one is an immune complex rapidly progressive glomerulonephritis, refers to GN associated with deposition of immune complexes in the glomeruli. So antibody formed for a reason or another, and antibody attached to antigens, and an antibody-antigen complexes form in the circulation and even in situ in the kidney, and at the end they cause the renal damage by multiple sub-mechanisms. Sometimes there is a clear clue for a specific etiology, like dominant IgA deposits, which happens in IgA nephropathy, and also subepithelial deposits and hump formation, like in cases of post-streptococcal glomerulonephritis. The third mechanism of kidney injury in such a phenomenon is post-immune rapidly progressive glomerulonephritis, referred to Rpgn association with small vesicle vasculitis, a necrotizing GN with a few or no immune deposits by immunofluorescence and electron microscopy. As you can see here, multiple glomeruli with variable involvement of the disease. Some of them are totally sclerosed, but you can see the one on the left, it's still having an active disease, and when we make it bigger, we can see the fibrin deposits going on. Some patients are positive for both ANCA and anti-GBM, so they will have ANCA vasculitis plus Goodbasture syndrome, and some of them have both ANCA and ANA or anti-DNA antibodies, so SLE with ANCA-associated vasculitis. Which one happened more of these mechanisms? So this is a study published by Janet, and she showed a large group of patients with rapidly progressive glomerulonephritis, more than 600 patients, focusing on the pediatric ones of them, 73 patients. We can notice that 42% of them has post-immune crescentic glomerulonephritis, and a little bit almost the same, 45% had immune complex crescentic glomerulonephritis. The lowest or the least was the group with anti-GBM crescentic glomerulonephritis, representing 12% of the group. So what are the differential diagnoses of crescentic nephritis? If we will go through the list, it is really a long one, but to make it simple, we can go for a categorical differentiation of these differential diagnoses. So starting from an anti-GBM, the second one is immune complex deposits, third one is post-immune, and those three are the same as from the mechanism of injury, kidney injury. Two added categories are the post-renal transplant and the Rpgn-like picture without crescents. The first one, anti-GBM. So it includes the anti-GBM nephritis, so isolated renal disease. If it includes the lung plus the kidney, it will be Goodbasture syndrome. If it happens in a post-renal transplantation in an Albert syndrome patient, it's also the same mechanism because the body forms antibodies against the collagen of the graft. Immune complex deposits include post-infectious glomerulonephritis, systemic disease, and primary GN. Post-infectious GN includes post-streptococcal GN, infective endocarditis, shunt nephritis, and Staph aureus sepsis, and other infections. For systemic disease, it includes SLE, HSP nephritis, and mixed connective tissue disorders. For the primary GN, it includes IgA nephropathy, C3 glomerulopathy, membranous nephropathy, C1q nephropathy. For the post-immune, it includes microscopic polyangiitis, granulomatosis with polyangiitis, which is formerly called Rpgn granulomatosis, and renal limited vasculitis, and eosinophilic granulomatosis with polyangiitis, formerly called Chardus-Truss disease. And also it includes idiopathic crescentic GN and medication-related. Post-renal transplant includes IgA nephropathy, anoxian-line purpura, C3 glomerulopathy, and SLE. For the Rpgn-like clinical picture, but without Crescent, it includes HUS, acute interstitial nephritis, diffuse proliferative GN. So among all these differentials, what are the commonest etiologies? So it differs from a place to place, but from a nearby country, which is Turkey, this is a 16-year experience of an 88 collected cases of Rpgn. They are all children. In that group, they found 26% of them are due to HSP nephritis, 22% are due to lupus nephritis, 18% are due to idiopathic, and 9% are due to post-infectious. 8% are due to IgA nephropathy, and same for C3 glomerulopathy, and half of that for post-immune, and there are some other causes. So what are the clinical presentations so we can recognize such a condition? So the presenting complaints in Rpgn may be of a severe nephritic syndrome, similar to those in severe post-infectious GN. The acute onset of microgyria, decreased urine output, hypertension, and edema. Another patient, initial symptoms being fatigue. Renal insufficient analysis. The urinalysis typically reveals hematuria, red cell, and other casts, and a variable degree of proteinuria. Patients with anti-GBM antibody disease may also have pulmonary hemorrhage and hemoptysis due to directly against the alveolar membrane.
Dr. Muhammad, can you close your camera so we have better internet connection? If you could close your camera, maybe we'll have better internet connection. Yes, thank you. Sure. Yes, go ahead. Sorry.
Sure. Similar findings can be seen in other causes of Rpgn, including granulomatosis with polyangiitis, microscopic polyangiitis, and lupus nephritis, in which there is also direct lung involvement. And any glomerular disease complicated by marked fluid overload and pulmonary edema. So the presence of pulmonary manifestation is not always vasculitis. Systemic complaints, including extrarenal organ involvement, are common in patients with post-immune Rpgn with or without ANCA positivity. The degree of renal impairment and the possible etiology. So does it associate, is there any clue from just looking for the degree of renal impairment and the possible etiology? So back to the same paper published by Janet from US. On the left hand, we can see the three mechanisms, the anti-GBM and the post-immune and the immune complex. And we can notice that regarding the creatinine, the group with anti-GBM has the worst renal function, then the group with post-immune crescentic nephritis, then the group with immune complex crescentic nephritis. In contrary, we can notice that those with immune complex has the worst regarding proteinuria. And after that, they group with post-immune crescent glomerulonephritis. Then at the end, the group with anti-GBM, and probably that's related to the impaired renal function, which impairs the filtration of the proteins in the glomeruli. Going to the evaluation and diagnosis, an accurate and urgent diagnosis is essential in the patient presenting with clinical findings suggestive of Rpgn. Patients should undergo appropriate serological assay and unless contraindicated a kidney biopsy. These serologic tests include ANCA, anti-GBM antibodies, anti-nuclear antibodies, and others as indicated from the biopsy results. Early diagnosis with kidney biopsy and serologic testing and early initiation of appropriate therapy is essential to minimize the degree of irreversible kidney injury. So going to the treatment, I will talk about the initial empirical treatment as other colleagues talk about the specific treatment for many of the conditions that might cause Rpgn. So empiric therapy may be begun in patients with severe disease, particularly if either kidney biopsy or interpretation of the biopsy will be delayed, which is one of the common challenges in our practice in many centers. More specific therapy can be given once the diagnosis is established. So in the KDIGO latest guidelines, they are recommending cyclophosphamide and glucocorticoids. And when they spoke about IgA nephropathy with Rpgn, they mentioned that patients with rapidly progressive IgA nephropathy should be offered treatment with cyclophosphamide and glucocorticoids in accordance with the guidelines for ANCA-associated vasculitis. There is insufficient evidence to support the use of rituximab or the treatment of Rpgn in case of IgA nephropathy. Also, when they spoke about IgA nephropathy in children, they mentioned that as in adults, children with rapidly progressive IgA nephropathy have a poor outcome, and despite limited evidence, this subgroup should be offered treatment with glucocorticoids, usually as methylprednisolone pulses and cyclophosphamide. They spoke about IgA vasculitis associated nephritis, HSP. They also mentioned the same. So children with IgA vasculitis nephropathy with nephrotic syndrome and or rapidly deteriorating kidney function are treated in the same way as those with rapidly progressive IgA nephropathy. In immune complex glomerulonephritis, for patients presenting with rapidly progressive crescentic idiopathic immune complex GN, treat with high-dose glucocorticoids and cyclophosphamide again. What about other therapies like plasmapheresis? So it might be indicated in cases with Vascular syndrome, with massive alveolar hemorrhage, and also in resistant cases of IgA nephropathy and cryoglobulinic nephritis, which usually are an adult condition, and ANCA-associated vasculitis with lung hemorrhage, and severe ANCA-related renal vasculitis. Other therapies include rituximab as a rescue therapy in cases of lupus crescentic GN, and also globulinic nephritis. So going to the case that I want to share with you, it's a 12-year-old girl presented to adult ER with nausea, vomiting, abdominal pain, and feeling ill for the last 2 days. And subhanAllah, I don't know how it didn't cross their mind, but she was still in the pediatric age group. And surprisingly, they didn't ask her or direct her to go to the pediatric ER. They just accepted the case and they assessed and they started. So during the assessment, they noticed the blood pressure is in the higher side, and she was edematous. Lab workup, initial ones, showed creatinine of more than 1100 micromole per liter, which is for our colleagues who are using milligram per deciliter, 14.7, and with echogenic kidneys bilaterally in the kidney ultrasound. She had also anemia, acidosis, electrolytes disturbance, and hyperparathyroidism. She was labeled as a case of renal impairment due to end-stage kidney failure, temporary HD catheter, which was exchanged with a permanent one later, was inserted, and she was started on regular HD, admitted under adult nephrology. Her other CKD problems were managed accordingly. Then she was discharged after around 4 weeks with an estimated GFR of 5 ml per minute. Upon referral to the kidney dialysis center in our medical city, that time only it was realized that she needed to be in the pediatric hemodialysis unit because of her age. The pediatric hemodialysis unit in charge, pediatric nephrology at that time, my colleague Dr. Al-Talhi, accepted the case, but because she was totally new to the team, he asked to admit her for a day to the pediatric nephrology ward for an initial assessment and baseline workup. That time I was the one covering the inpatient services. So after revising the case, when the resident presented the case for me, she told me that the child had renal impairment since 1 month. And that time I asked her what was the primary kidney disease. She said unknown. Actually, the child was free medically from before. And because that contradicts the definition of chronic kidney disease, which is at least 3 months of renal disease. So we looked for other parts of the assessment. So that child was thriving well, and she was having hematuria, even not just in the urinalysis that we did, even the ones that was done initially upon her presentation 1 month back to the adult emergency department. Her kidneys were normal in size and the ultrasound, despite their increased echogenicity. They were not small like those with chronic kidney disease. So our impression at that time was it is rapidly progressive glomerulonephritis. So the question came up was, is it effective to treat Rpgn if started late? Is it too late to start, or we can give a chance to the patient? That time, because I was the most junior consultant in the department, I consulted my senior colleagues. They advised me to give the patient the benefit of doubt, start the treatment, hoping that she might respond. So when she was admitted to our ward, she was on hemodialysis. Her eGFR was 5, and C3, C4 were normal, and TGBM were negative. Both anchors were negative. We started her treatment with IV pulses of methylprednisolone, then switched to arprednisolone, and IV cyclophosphamide monthly for 6 doses, then switched to oral Silcept. The biopsy was done. It showed the biopsy reports came later as post-immune crescent glomerulonephritis. So this is her creatinine level at the beginning when she presented at the 10th of October to our adult emergency. So it was 1,133 micromole per liter. So when she was admitted to the pediatric nephrology ward because of hemodialysis, her creatinine was 435. After starting therapy, like 3 to 5 days, her urine opened up. She started to urinate. Later, hemodialysis was discontinued, and she was discharged after 2 weeks with a creatinine of 173. Later, she came for next month for the first follow-up visit. Her creatinine was 125. After another 1 month, it was 91. In February, it was 98. March, it was 100. And in April, it was 93. She missed her appointment for around 4 months. Then she came in August with a creatinine of 80. And later, by the end of the year, her creatinine was 79. The estimated eGFR that time by CKD-AP formula was around 112 milliliter per minute. Later, the patient continued to follow up, and I noticed that she had a persistent significant proteinuria, started on ACE inhibitors. Her renal function slightly declined, and her eGFR, before I transferred her care to the adult nephrology clinic by the age of 14, was around 90. So, as a take-home message, Rpgn is a serious condition that leads to end-stage kidney failure if not treated, which emphasizes the importance of early recognition. Initial empirical treatment with steroid and IV cyclophosphamide. Treatment, even if late, improves the prognosis. Renal biopsy and serological studies are important to find the diagnosis and guide further treatment. And thank you.
Thank you so much, Dr. Muhammad, for this informative lecture. I personally enjoyed hearing about the history of Rpgn and the new guidelines and about therapies. Before we start with questions, let me just say one quick comment. The Q&A is mainly for questions related to the lecture. It's not for people to write their names to get CME. So it's really hard to find the questions. Anyhow, we have a couple of questions. The first one, as you pointed, Dr. Muhammad, biopsy is not always easy. Sometimes you need to start empiric therapy immediately. The question is that, let's say you have a patient and you started empiric therapy without a biopsy, and that patient has improved clinically and laboratory-wise has improved. A week or 2 weeks later, you were able to find or arrange logistics to do a biopsy. Is there a utility of doing a late biopsy in such patients?
Thank you very much for this question. Actually, it's really difficult to answer such a question. I didn't come across any follow-up biopsies done for patients with rapidly progressive nephritis, so I'm not aware of what expected results might be there. So it's really difficult to answer this question. If I'm in that position, I will not go for. Actually, it's really difficult to answer. So if that's the case, I don't know what's the answer. Actually, it's really difficult.
Sorry for that question. It's a question that our team encountered recently, and we had a grand round talking about this. So I apologize again.
No, it's okay. It's okay.
I have another question. In case of Rpgn, how do you interpret the improvement in renal function to type of Crescent in the biopsy, and also to late start of treatment since presentation?
Can you repeat the question, please? I couldn't get it.
In case of Rpgn, how do you interpret the improvement in renal function to type of biopsy and to type of Crescent in the biopsy? I assume the person asking the question, his Dr. Muhammad Karar, is trying to say, how do you know there is an improvement? How do you assess improvement, and how do you assess response to therapy in Rpgn?
So initial response includes the open up of the urinary of the urine output and the later drop of the creatinine and the renal function test. Later, the ability to discontinue patients who were started on dialysis from dialysis.
Okay. Next question by Dr. Muhammad Ahmed Abdullah. If glucocorticoids are the main treatment option, does renal biopsy with its hazards mandatory in most cases? Do we need to do a renal biopsy if steroids is the main therapy?
Okay, so regarding the fears of renal biopsy by many people, especially intervention radiologists, which usually they ask us for an excellent level of hemoglobin, at least 10, sometimes they might accept 8, because they are afraid of the complication of renal biopsy. So we had a retrospective study that made, was one of the authors, was not yet published. We are seeking publication about the complication of renal biopsy in children. So in the group of children who were biopsied in our hospital, we didn't have any serious complications from renal biopsy, except on children with hemolytic uremic syndrome, those with low platelets. So for those with Rpgn, we didn't have any serious complication. Those with nephrotic syndrome, we didn't have any serious complications. So fearing the hazards of renal biopsy seems to be more than needed. So if we took proper precautions and it is done by well-trained hands, the risk of having serious complications are very low. On the other hand, glucocorticoids, if someone is in doubt or he's having difficulty to have an access of immediate renal biopsy for a reason or another, some people might be worried if they started the glucocorticoids might change the picture of the renal biopsy. So it was found that the glucocorticoids and plasma exchange usually does not change the picture on the renal biopsy immediately. It needs some time. The cyclophosphamide do, and for that, it's better to go for a renal biopsy before cyclophosphamide, unless that was not feasible. So the priority is to administering the appropriate treatment.
Absolutely. Thank you so much, Dr. Mohammed. If you allow me, if you can turn off your video, because your audio is clear when your video is off. I think it's probably, yes, thank you. One last question, or probably just two last questions. Number one is, the case that we discussed earlier, how long do you need to follow them up? This is a question by Dr. Asma. How long do you need to follow these patients?
That's really interesting question. And for me, I continue to follow them till they reach the adult age. So in Saudi Arabia, most of the MOH hospitals, it's 14. So because they had a severe acute kidney injury, and the probability of having chronic changes in their kidneys are high, and they might develop hypertension and proteinuria later on. So continue follow them up to make sure they don't develop these possible chronic complications are necessary. Actually, in the same patient, after 1 year of follow-up, I noticed her proteinuria, started her on ACE, and proteinuria improved, but not so partially improved. I couldn't raise the dose furtherly because it causes her side effects. However, when I transferred her to adult care or adult services, she was still having borderline proteinuria. And maybe in the future, she might develop also hypertension. So this is the importance of continuous following them up. I don't know from the adult nephrology side for how long they will continue following them up, but I teach usually my patients who are at risk of developing renal sequelae in the future, at least if they cannot follow up with a nephrologist, to do a yearly blood pressure measurement and urinalysis in their next primary care center, and in case there is hypertension or proteinuria, to ask for a referral to a specialist nephrologist.
We have several questions that we are trying to cover in a very limited time. I'll take one last question, and then if your time allows, if you can type the answers for the other ones. This last question by Dr. Iman Noreddin, our colleague. Any data regarding the % of patients with renal recovery after treatment?
There is a good percentage. I'm not able to recall the number, but the data are really promising. So for those who are receiving treatment, most of them do respond. However, some patients still are resistant, even after adding plasmapheresis and other rescue managements.
Thank you so much, Dr. Mohammed. We have limited time. We have so many people asking questions. If you can answer them in the Q&A. I would like to thank again the organizing committee. Congratulations for the successful conference. And now we move to the next lecture.
Thank you, Dr. Ibrahim. Thank you, Dr. Mohammed. We will move to the Industrial Symposium. Dr. Abdul Karim, تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's really my pleasure to be part of this nice symposium. If we look at the number of the attendees, it's really something amazing and exceptional that 3,000 attendees, for the second day. Would like to thank the organizing committee, Prof. Khalid Sahran and Dr. Khalid Hassan and their colleagues for excellent and preparing this nice symposium. To move to talk about our, this talk, I would like to welcome and introduce also Ms. Hind Al-Khater, who's graduated with a bachelor degree in biochemistry, and also she has later on a master degree in pharmacology and nutrition. And Ms. Hind, she had very extensive experience, more than 19 years in business development in many pharmaceutical and medical devices. She is responsible for the marketing strategy and clinical development of mid-surge solutions across all the Gulf countries. Her topic really very interesting because now, especially with the COVID-19 era we had, and we're facing a lot of patients who develop acute kidney injury with sepsis and some sort of infection. And we have now the integration between the technology and also the science to find a solution which will change the outcome of critically ill children with our patient who develop AKI. Ms. Hind, you are more than welcome, and you can start.
Thank you, Dr. Abdulkarim. Assalamu alaikum jami'an. Good evening. We are honored to be part of this great symposium. Thank you for inviting us to participate. Thank you, Dr. Khalid. It was a great pleasure that we support the educational activities of the King Saud, also of the Saudi Society of Nephrology. So our mission has been always to support the educational activities and to be the link between the latest technologies worldwide and the healthcare professional in the area with the goal of improving the quality of life of our patients and to solve tough challenges where there is critical patient need. And I will speak tonight about the improvement of the outcomes for sepsis patient with Oxiris while delivering the CRRT. Can you see my screen?
Yes, we can.
Okay.
Yeah.
So speaking about the sepsis, it's a major and growing global healthcare challenge. So it's a life-threatening syndrome and many reasons are available for the increasing impact of sepsis. And multiple campaigns are focused on bringing together professional organization with the unified aim of improving the outcomes and reducing mortality from this sepsis. Us also, in MedSearch Solution, we are combining our efforts to save our patient lives in the area. Inshallah, we can do it. I speak about Oxiris. So what is the advantage of this Oxiris and why we are focusing on it today? Actually, the use of Oxiris have suggested potential for clinical improvement in organ function and hemodynamics in some patients with sepsis or septic shock. It's the only 3-in-1 blood purification filter set to effectively remove the cytokines and the endotoxin as adjunctive therapy for sepsis management while delivering CRRT. So we have growing evidence. Many studies on the use of Oxiris have suggested the potential for clinical improvement in organ function and hemodynamics in some patients with sepsis or septic shock. And this filter is designed to simplify the blood purification therapy delivery for the patient requiring both cytokine and endotoxin removal and CRRT at the same time. And this will free up nursing time. With sepsis, we are facing many challenges. So we have high rates of mortality and morbidity, speaking about the incidence. The analysis of data from the Global Burden of Diseases study estimated the total number of cases in 2017 to be 48.9 million. So it's really a very high number, with up to 11 million deaths, representing around 20% of all deaths worldwide. So really a very high number. Even for the reported hospital mortality, for the sepsis, we have 20 to 45%, and for septic shock, 50 to 60%. So who is at risk? Anyone with an infection is potentially at risk of developing sepsis. The infants, elderly, actually the children are at higher risk than adults for developing the complication associated with CRRT, and this is due to the large extracorporeal volume in proportion to their body volume. And this will predispose us to hypotension at the time of the connection. And also, who is at risk? The people with a weakened immune system or a chronic illness, and those recovering from recent surgery or a serious illness. So sepsis is a frequent occurrence among critically ill patients in the ICU. Also, early diagnosis is really challenging. Diagnosis of sepsis in critically ill patients can be challenging due to a lot of reasons. For example, if we have prior use of antibiotics or clinical manifestations that can be complicated by some comorbidities, if the critically ill population, maybe they have other type of disease, or we will have the result of inflammation caused by other underlying disease. So it's really challenging. And as per the third international consensus definition for sepsis and septic shock, we had the 3 criteria for this sepsis, and as you can see, it reflects a greater understanding of the pathophysiology of the sepsis, recognizing the presence of organ dysfunction as part of the definition of sepsis, and also they're using the SOFA score, which is typically used to assess a patient's organ function status during their stay in the ICU, and this was published by Ronco in 2019. So sepsis is caused by a dysregulated immune response. We have the normal immune response in our body, for example, when we have recognition of a pathogen, but also we have the dysregulated immune response that can result in the excessive release of pro and anti-inflammatory cytokines, which may trigger a series of reactions and that can lead to cellular and tissue injury. So, for example, we have excessive cytokine release, interleukin-6, interleukin-8, many cytokines. So, as a result of this sepsis, so they wanted to check the level of circulating endotoxin for patients with sepsis and septic shock. And there was one single center prospective observational study that was conducted between January 2007 and December 2012 to check the prevalence and the clinical significance of the early high endotoxin activity in septic shock. And as you can see, they had 107 patients with septic shock, and they measured the endotoxin activity within 24 hours of the septic shock onset. So the data shows that 82% with septic shock were found to have either intermediate or high endotoxin activity levels. So if we can help to remove those endotoxins, maybe we can save the lives of our patients and improve their lives. So that's why I'm speaking about this study. And also here, the association between cytokine levels in patient blood samples taken during the first 24 hours following admission to the ICU and mortality was investigated in patients with sepsis and septic shock. So also, a study, it was a prospective observational study, 29 patients with septic shock, and they did cytokine profiling from this single blood sample that was taken within 24 hours of ICU admission. And the results, the plasma interleukin-6 levels in non-survivor patients were significantly higher than in survivors. So this elevated the plasma cytokine levels, and particularly with the interleukin-6 are usually associated with increased risk of mortality following the ICU admission. So this can be predictive for us. And also when we have sepsis, we may have organ failure. So these pathologic effects can result in the failure of one or more organs, depending on the medical situation of the patient. 20 to 25% of those patients who are hospitalized, okay, they with sepsis can have multiple organ dysfunction, and they for sure will have increased risk of mortality. So we can have regulated immune response in sepsis and damaging many organs, including cardiovascular, hepatic dysfunction, neurologic, respiratory, and even renal dysfunction. For example, for the renal, they reported to have 22 to 69% of the patients with sepsis. So it's really a very high number. Now, moving to the management of the sepsis, the multifaceted approach to sepsis management, and for sure, starting with the fluid resuscitation and the hemodynamic support. So let's say the measuring the lactate level if it is available in the hospital, using, for example, the norepinephrine as a first choice vasopressor, the infection control, speaking about the antibiotics, the general supportive control, including, for example, the pressure ulcer prevention, the prevention of thromboembolism, and at the end, the management of organ dysfunction that can be done with mechanical ventilation and the renal replacement therapy that can be also continuous or intermittent, and depending for sure on the clinical manifestation of the sepsis, on the medical situation of the patient. So blood purification therapies are adjunctive therapy options for sepsis management, and they are also be associated with improvement in certain patient-related outcomes, such as organ function and hemodynamics. The Oxiris filter set, so it is approved for use and indicated for use with the PrismaFlex or the PrismaX control unit for the patient in need of blood purification, including the continuous renal replacement therapy, and in conditions where the excessive endotoxin and inflammatory mediator levels exist. So the set can be, it is intended for use in all the CRRT therapies. Okay, and what are the advantages of this Oxiris? As I said before, it's the only 3-in-1 blood purification set to effectively remove the cytokines and the endotoxin as an adjunctive therapy for sepsis management while delivering CRRT. So in just one device, we can have all of those advantages, including that can help to reduce the thrombogenicity, and in the same time with the surface treatment, absorbing the endotoxin and the AN69 base membrane, which is absorbing the cytokines and the toxins while providing continuous renal support. As I said at the beginning of my presentation, we have some clinical evidence that is encouraging physicians, and the studies on the use of this Oxiris have suggested the potential for clinical improvement in organ function and hemodynamics in some patients with sepsis or septic shock. I'll go through only two of them. So Turani study, so it's a retrospective baseline controlled case series, and it was published in 2019. So they took 60 patients with sepsis or septic shock, of whom 85% had AKI, and the protocol was the hemodiafiltration with Oxiris filter set and they checked regarding the functional observation after the treatment with Oxyris. So it was really impressive for the patient outcomes. So they had decreased levels of pro and anti-inflammatory cytokines for the interleukin-6 and interleukin-10 and other markers of infection. So as you can see on the screen, the change from baseline in those parameters to the end of the treatment with Oxyris. So they had endotoxin activity decrease by 22%, the cytokine interleukin-10, 74% decrease, for the interleukin-6, also 75%, and for the procalcitonin, 73%. Also, there was change from the baseline in the hemodynamic and respiratory parameters to the end of the treatment with Oxyris. So there was increase for the MAP, and also, as you can see, for they had decrease and significant decrease for the norepinephrine dosage. So, and it was really impressive for them. Also for the partial pressure of oxygen and the fraction of inspired oxygen, there was increase. So improvement on all levels for those patients. And at the end, also there was improvement for the SOFA score with this product. The second one, it was the two French centers, retrospective, also baseline controlled case series. They took 31 patients with septic shock and AKI, and also CRRT performed using the Oxyris session. So regarding the key observation, first of all, there was change from baseline in clinical parameters following 48 hours of this treatment. So as you can see also the decrease in the norepinephrine dosage, and also it was 88% and the lactate level 75% decrease. So a product, in one single product, we can have 3-in-1 blood purification filter, removing the cytokines and the endotoxins in the same time as an adjunctive therapy for the sepsis management while delivering CRRT. And we have some studies that are encouraging, really encouraging, and showing that we have organ function and hemodynamics in some patients with sepsis, improvement of those hemodynamics in some patients with sepsis and septic shock. So it's designed, as I said, to simplify the blood purification therapy delivery for those patients requiring cytokines and endotoxin removal and CRRT. Our path towards excellence in saving patients' lives. Would like to thank you for the privilege to address you, and I'm ready for any question.
Okay, thank you, Ms. Hind. Ms. Hind, and you know, this topic, I think, you know, all of us are really interested in that one, especially now, as I mentioned in my introduction, with the era of COVID-19, and has been really, you know, showed in certain studies in adult and also some in pediatric regarding now that extracorporeal treatment for patients with sepsis and AKI. It may change really the outcome, because as a nephrologist, sometimes we face difficulties regarding our management strategy based on really conservative management. So thank you, Ms. Hind, and I would like now to open the floor for the questions, because I can see.
Abdul Karim, if you allow me.
Thank you, doctor. Actually,
okay.
if you let me speak a little bit.
There's one question now regarding will Oxyris use improve necessarily the length of BSU stay and decrease length of term or long-term CKD development?
Thank you, Dr. Abdul Karim. I wanted to speak regarding your comment about.
Is that question clear?
Regarding your comment about the COVID-19 patients. Actually, the FDA emergency use authorization of the Osiris filter set. So there was an FDA approval for the emergency use of this product for those patients with COVID.
Sorry, is there any issue with your sound? Because to me there's an interruption.
Ms. Hind, are you still with us? You are on mute.
Okay. Okay.
Hind, you are muted, yeah, Hind. Just press the button of the mics. You are muted, Hind.
You can hear us? Can you put unmute?
Okay, seems to be she's facing with a technical issue. Okay, if Ms. Hind, she cannot come back, we have a few minutes, but in case if there's any comment from the people around before we'll conclude.
Yes, Abdul Karim, if you allow me. But I wish that Dr. Hind is here because, you know, whenever we are using a membrane of AN69, usually we get thrilled and worried about any allergic reactions. So all the allergic reaction to the filter is linked to this type of the filters. The other question is any precautions of using of the filter if the patient is on ACE on ARBs, because there is couples of flags about using it during using the Osiris, because again, it will induce allergic reactions.
Well, and we'll come back. Let's make a comment about this one. You know, this is really the Osiris is special one, special filter, and the claim that really it will work to remove both the cytokines and also the toxins, and also it will really minimize the need for the certain inotropes. So this is the reason, based on certain studies, they found that it really will add clinical benefits regarding the outcome of the AKI, especially in the sepsis setting. So it really, to me, it seems to be its open new hope that we can change the outcome of AKI rather than just using the conservative management or strategy in managing AKI. Okay, I think there is a technical issue with Ms. Hind, and I would like to thank our speaker and really to find excuse for her for the technical issue she is facing. And I would like also to thank the attendees who is with us and to move to the second session. Thank you.
Thank you.
Thank you, Dr. Abdul Karim. Thank you very much. And now we will move on to the next lecture. Dr. Al-Anud, if you can introduce yourself and the speaker, please.
طيب السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. Good evening, everyone. My name is Al-Anud Al-Shami. I'm a pediatric transplant nephrologist from King Fahd Specialist Hospital, Dammam. First of all, I'd like to echo all my colleagues in extending congratulations for the organizing committee and in particular for the scientific committee, actually, for choosing a very interesting any topics that attracted more than 3,000 حاليا attendees over a weekend. يعني احنا we're around 8:30 and it's still more than 3,000. Congratulations. I think you raised the bar very high for the upcoming conferences. Our next speaker is a well-known figure internationally and nationally in the field of pediatric nephrology, Professor Jamila Gari. So Professor Jamila Gari is a professor in pediatric nephrology, and she's the chairwoman of the Pediatric Nephrology Center of Excellence in King Abdulaziz University in Jeddah. And to be honest, she has, mashallah, a lot of achievement nationally and internationally. Maybe probably one of her main achievements nationally is the establishment of the pediatric nephrology excellence units in Jeddah. It's a very comprehensive unit, and I believe she's the first one who established hemodialysis in Jeddah. She's an excellent researcher with multiple research awards, and multiple publication, maybe more than 150 publication in a peer-reviewed journal. She's a member of in a more than 7 كمان well-known organization nationally and internationally. She has received multiple awards, and maybe one of the recent and most important awards is the Lifetime Achievement Award from our Saudi Society of Pediatric Nephrology. I think if I continue talking about Professor Jamila, I'll continue until the night, and time will not, mashallah, allow me to finish. So without further ado, please help me welcoming Professor Jamila. Professor Jamila, the mic is yours.
اوكي السلام عليكم ورحمه الله وبركاته. تسمعوني الصوت كويس؟ الصوت كويس؟ بتسمعوني؟
Yes.
طيب thank you very much Dr. Anud for generous introduction. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. I will talk about renal stone disease in the Kingdom of Saudi Arabia. To start with, a quick overlook about the renal stones in adults. Urolithiasis is the most common adulthood urological problem worldwide. It is multifactorial disorder which results from the interaction of several environmental and genetic factors. The incidence is high in North America with 7 to 13%. It is high in Europe of 5 to 9%, and it is low in Asia of 1 to 5%. I will just put the pointer. Okay, what is the situation in our kingdom? It is high, as shown by this study from Riyadh, where they surveyed visitors to a local clinic. They found the prevalence of 19.1%. My colleague, Prof. Osama Safdar, he did a study, and the students worked with him. They tried to direct the questionnaire to responders from all over the kingdom, and the prevalence was 9.1%. However, the same authors, they tried to study the prevalence in Jeddah, Riyadh, the 2 big cities, and they found the prevalence high of 16.4% with the risk factors mainly with males and the age group of 34.4 to 34 and 40 years, indicating the importance of environmental factor and of lifestyle. Over the last decades, the incidence has increased in all age groups, all genders, and all races, with high reported chance of recurrence in those who are affected, with 50% chance of recurrence within the next 5 years of diagnosis. Family history also very important, as it is very common among the first degree relative of people affected with renal stones. All types of renal stones, nephrolithiasis, where the stone is in the renal pelvis, or urolithiasis, where it is inside the lumen or in the lower renal tract or in the bladder, and nephrocalcinosis, where the calcium is integrated in the parenchyma. All of those varieties are uncommon in pediatric age group. However, cases in children are increasing. It had been reported that up to 6 to 10% annual rise in the incidence over the last 20 years. Nephrolithiasis could be challenging in children, and I will try to demonstrate that through a few cases. Case 1 is Sarah. She is a 2-month-old, presented to one of the private hospitals in Jeddah with septic shock. She required a PICU admission, transferred to our hospital as a case of acute kidney injury caused by septic shock, which required peritoneal dialysis. Unfortunately, she did not recover, and she ended by end-stage kidney disease on peritoneal dialysis. There was consanguinity. Her parental grandfather had end-stage kidney disease, which required transplantation, and unfortunately he died early at the age of 50 years following an episode of rejection. On examination, she had nystagmus, and fundus examination showed retinal degeneration with pale color retina and macula with markedly decreased rods and cones. Her initial renal ultrasound did not show any calcification or stones. It showed only bilateral increased renal cortical echogenicity. We have repeated the ultrasound 6 weeks later, and again the same finding, only of increased echogenicity with no evidence of stones or nephrocalcinosis. Because of her nystagmus, we did a genetic study, and it came as positive for AGXT, which is the gene for hyperoxaluria type 1. We sort of did not believe this, so we asked our friend Friedhelm Hilbrand in America to repeat the test, and it came with the same diagnosis of hyperoxaluria type 1. Because the child was anuric, so we did plasma oxalate, which came as high of 74.4. So Saraj had hyperoxaluria primary type 1, which affects 80% of those affected, type 2, 10%, and there is also type 3, and secondary hyperoxaluria. It can result from malabsorption or low calcium diet. Dr. Adi Herbish, he will give a talk about hyperoxaluria, and I'm sure he will elaborate much more. But the defect in hyperoxaluria type 1 is in the conversion of a glycosylate to glycine, and this will result in conversion of glycosylate into oxalate, which will be deposited in different tissues, including the kidneys, causing kidney damage. We are in the process in the kingdom of collecting our genetically proved hyperoxaluria in one paper, and it is led by King Saud University by Dr. Majid Al-Fadl, and we have 25 cases. It is in the process of writing up the paper. However, this paper from Arab country, Tunisia, they reported primary hyperoxaluria in infancy, 14 infants with a median age of 2 months, similar to our patient. At the diagnosis, 11 of those children had end-stage kidney disease. All patients had nephrocalcinosis, and 2 of them had calculi. The unusual thing in our case was there was no nephrocalcinosis. The diagnosis in 9 patients based on positive family history of hyperoxaluria, bilateral nephrocalcinosis, or quantitative crystalluria. Genetic study was used only in 4 children, while renal biopsy was used in 1 case for diagnosis. At the time of publishing the paper, only 2 children had normal kidney function because they were sensitive to pyridoxine, vitamin B6, while 7 of the 11 patients died, and 4 children were on peritoneal dialysis. So they concluded that children with infantile hyperoxaluria and end-stage kidney disease at high risk of early death, and of course, they stressed on the importance of combined liver and kidney transplantation in those children. Hyperoxaluria could be treated with alkalinization of the urine, pyridoxine, and the new treatment was lumasiran, which will be elaborated in the next lecture, as well as taking steps in prevention of oxalate production by the diet. The second case, another type of renal stones in children, Hafsa, she is a 4-year-old Pakistani girl, presented to our charity center with a diagnosis of multiple stone. There was positive consanguinity between the parents. The mother, she reported that at the age of 5 months, and another episode at the age of 1 year, she noticed reddish brownish discoloration of the diaper with pink crystals, and urine analysis revealed RBCs. And this is the picture of the nappy. The mom, she took this picture. There was a history of UTI, and the renal ultrasound showed multiple stones, and stone analysis revealed uric acid. So the child had uric acid stone and at presentation, the kidney function was normal. The genetics showed the mutation of adenine phosphoribosyl transferase, which is autosomal recessive, characterized by excessive production of renal excretion of 2,8 dihydroxyadenine, which lead to kidney stone formation and crystal-induced kidney damage. So the child had purine stone, which could be caused by uric acid as a result of familial juvenile hyperuricemia, and this is autosomal dominant and result in abnormal tubular handling of urate, or as a result of leukemia or lymphoma or Leishman syndrome, which is autosomal recessive syndrome. Or it could be purine stone secondary to exanthinuria, such as the xanthine oxidase deficiency, or similar to our case, which is APRT deficiency. The third case is a 3 years old Syrian boy, not known to have medical illness before his presentation to our center back on 2018. He presented to the ER with urine retention, pain, and abdominal distension for 2 days previous to presentation. There was no history of fever or change in urine color. There was positive consanguinity between the parents with a strong family history of renal stones in his family, in both the brother and the sister. He had facial acne on forehead. He looks obese with broad shoulders and hyperpigmentation. You can see his picture here with acne, and also you can see his picture here with broad shoulders. His growth was in the third centile for both weight and height. He had high blood pressure, probably related to the fluid overload, and he had distended abdomen with palpable bladder. He had evidence of precocious puberty with Tanner staging 2. At presentation, his creatinine was high of 580, and high urea. Also, he had high potassium, high phosphate, low calcium, and low hemoglobin with hematuria, pyuria, and proteinuria. So we were sort of unsure, is it chronic problem because of the high phosphate and low hemoglobin? His renal ultrasound, as you can see here, showed bilateral renal stones, which was confirmed by the CT scan, and also it was seen in the KUB in the plain abdominal X-ray. So we referred him to our urologist, who they put DG stent, and then the child became polyuric with a 12 ml per kilogram per hour. Immediately his kidney function improved, as you can see here, in both urea and creatinine. And as you can see here, his kidney function was initially 580, and within few days, it was back to normality of 54. And actually, he was seen in our clinic on 30th of January, last January, and he's still having normal kidney function. As investigation of his renal stones, we did the urine studies for oxalate, citrate, the cysteine, uric acid, and calcium. And as you can see, his urine cysteine was very high, indicating that he's having cysteinuria. For the precocious puberty, his MRI showed adrenal tumor, as you can see here. And also his investigation showed he had high testosterone and high dihydroepidisterone, and for that he had a surgical excision of his tumor, which resulted in that his testosterone is normalized soon after the surgery, as you can see here. And in his last visit last January, it was still normal, and here also it was normal. His genetic study showed 2 genes, SLC3A1, which is a cause of cysteinuria, and another gene which had been reported to be associated with adrenal tumor. This is his picture on his first discharge from our hospital. Very lovely boy with no acne and happy with his toy. So he had cysteinuria, which is autosomal recessive mutation caused by a couple of mutations, SLC3A1 or SLC7A9, and both of them, they interfere with the handling of proximal tubules and intestinal tract of diphasic amino acid, cysteine, ornithine, lysine, and arginine. And this will lead to the defective reabsorption of those amino acids, and they will lead to the formation of the stone. The only phenotype of cysteinuria is the renal stones in affected individuals in the lifetime. Sorry, I'm not sure it is not moving. 1 second. It's sort of stuck. Sorry, yes, surgical intervention is necessary in most of the children, but the cornerstone of treatment are dietary medical prevention and of recurrent stone formation. The solubility of the salt will increase 3-fold with alkalinization of the urine, and therefore alkalinization of the urine is part of the treatment using chelating agents such as dibenzylamine or thiol, which is the name for mercapto. Propionyl glycine is useful as well. This is a study from Kingdom Saudi Arabia, multi-center study, actually led by King Saud University, but we are part of that study. They collected all children who are genetically proved cystinuria, 23 children. With male predominance. 13 of those children were homozygous and 2 were heterozygous for SLC3A1 gene, while 7 children were homozygous and 1 combined heterozygous for SLC7A9. There were 12 genetic variants, including 5 novel variants. 21 children required surgical intervention, but none of them developed end-stage kidney disease. The median age at first presentation with renal stone was similar to our patient of 3 years, but the range was quite wide from neonatal period to 20 years. 39% of the children presented within the first year, 30% between 1 and 5 years, and 22% between 5 and 10 years. So 90% presented before 10 years of age. Stone formation per year varied widely with a median of 0.45 stone per year. So we had a case of hyperoxaluria, and we had a case of uric acid stone, purine stone, and we had a case of cystinuria. The fourth cause is hypercalciuria. Just because of the time, I didn't bring a case, but it could be caused because of inherited tubulopathy, which could result in isolated hypercalciuria, such as a Bartter syndrome or familial hypomagnesemia hypercalciuria nephrocalcinosis syndrome or autosomal dominant hypercalciuria. Or it could be caused by inherited tubulopathy results in hypercalciuria and hyperphosphaturia, such as Dent disease, which is X-linked recessive, or Lewis syndrome, which is oculocerebrorenal syndrome. What about presentation? The presentation could be like our first case, vague symptoms such as nausea, vomiting, irritability, UTI could be the main presentation. Maybe she had UTI and resulted in sepsis and then acute kidney injury, and she had this stormy course. The common presentation is hematuria and urinary tract infection. In older children, flank pain is common. Hematuria occurs in 90% of children, either microscopic or macroscopic. Incidental finding had been also reported in considerable number of cases. So for the stone formation, it requires that the solute is higher than the water. So that's why it is very important for children to drink plenty of water to prevent further stone formation. And also it is a balance between promoters, which are the salts oxalate, calcium, cysteine, or uric acid, or inhibitors such as citrate, and attachment of growth of crystals into nephrolysis due to the epithelial abnormalities. Environmental factors is very important in adults. However, in children, genetic and metabolic disorders are the main causes of childhood nephrolithiasis, urolithiasis, and nephrocalcinosis. There is a shift in the cause. In the past, infectious cases were mainly the underlying cause. Now we observe that the metabolic and genetic causes are the main causes. The genetic causes such as distal renal tubular acidosis, which results in nephrocalcinosis, familial hypomagnesemia hypercalciuria nephrocalcinosis, which results in both nephrocalcinosis and nephrolithiasis, and this disease, which results in both of them. What about the risk factors for recurrence, which is up to for recurrence, which occurs in up to 50% of children. Metabolic and genetic predisposing factor carries high incidence of recurrence, and the recurrence occurs mainly in children less than 10 years of age, and it had been reported an up of 1/3 of hypercalciuria, 50% of hyperuricemia, and 20% of cystinuria. Also, stones are associated with systemic disease such as Crohn's disease associated with calcium oxalate, uric acid stone, cystic fibrosis with calcium oxalate, meningomyelocele with tyrosine stone and calcium phosphate and oxalate stone, seizures and convulsions where children could be treated with ketogenic diet, and this will result in calcium oxalate and uric acid stone. So how to go about diagnosis? Very important to see those stones using imaging, and the sensitivity of ultrasound is 76% compared to 100% with helical CT. So helical CT is the best imaging for renal stones. Urine studies are very important. Either we use a spot urine and we ratio that to the creatinine, or 24 hours urine studies. A blood test could give very important indicators such as hypomagnesemia in familial hypomagnesemia, hypercalciuria, nephrocalcinosis syndrome. Stone analysis tells us a lot of information about the type of the stone, such as the second patient when we found the stone, that it was uric acid stone. Genetics, in my opinion, is crucial to diagnose those children. So as we have mentioned, urine studies can give us a lot of information. Renal function test is very, very important to check and to find out the function of the kidney, electrolyte, potassium, hypokalemia, and dysuria and tuberculosis, and different salts can give us indicators. Hypercalcemia could be associated with hypercalciuria. Hypercalciuria could also occur alone, but we have to check for hypercalcemia, and if there is hypercalcemia, we have to find the underlying cause. Is it hyperparathyroidism? Is it hypervitaminosis? What about the situation in our kingdom? This is study back in 1995, where Dr. Rashid, he reported 71 children from the South with incidence of 1.2 per 1,000 pediatric hospital admissions. They were reported to have nephrolithiasis. The mean age at presentation was 12.3 years. The principal presenting symptoms on those patients was abdominal pain or flank pain. 21% of the children had UTI, urinary tract infection. 4 patients had congenital anomalies of the renal tract. And only 5 patients were labeled as metabolic abnormalities. 1 had hypercalciuria, and 1 had hyperoxaluria, 1 had hyperuricemia, and 2 had cystinuria. And 67% were reported as idiopathic. What is that change in our kingdom? Our diagnostic facilities have improved a lot over the last 3 decades. This is a study between King Saud University and King Abdulaziz University. We studied 144 children with renal stones. And as you can see, the age of the diagnosis is much younger now. For nephrolithiasis, 7 years. For nephrocalcinosis, around 6 years. For nephrocalcinosis is for 4.5 years. Similar to all other studies, family history was very prominent, as well as consanguinity was very common. Out of those 144 children, 86 children, 60% were diagnosed as metabolic or genetic causes, while 58% were UTI or undetermined cause. So we took those 86 and we studied them in another paper, and we found that 53% of them were caused by metabolic causes, either hyperoxaluria, cystinuria, hypercalciuria, or hypsuria. 18 children had familial hypomagnesemia, hypercalciuria, nephrocalcinosis, and 15 children had distal renal tubular acidosis. When we looked at those caused by metabolic or hereditary causes, again, the age of diagnosis for the 3 groups were around 5.5, 6 years, and the consanguinity and family history was very common. So similar to other reported literature, that family history is very common in those families. What about the presentation? Similar to previous literature, we found that flank pain and hematuria was the main cause with the main presentation. The etiology was determined In the majority of our cases, it was determined in 78% of cases of nephrolithiasis, and of those 69% were metabolic, and the underlying cause in nephrocalcinosis was found in 86% of cases. In nephrolithiasis, those who were diagnosed and we found the cause, 69% of those 78% were caused by metabolic causes, 20% had UTI, 5% had dysteria and tuberculosis, and 28% had congenital anomaly. And of those of congenital anomaly, some of them had UTI. And while the group of nephrocalcinosis, 9.8% of them had congenital anomaly. For the nephrocalcinosis, the underlying cause was found in 86% of them, 35% familial hypoenzyemia hypercalciuric nephrocalcinosis, 23% were distal tubercular acidosis, 7% Bartter syndrome. The laboratory studies was very useful in diagnosing those children. Urine studies to find if they had hypercalciuria or hyperoxaluria or hypermagnesiuria by calculating the fraction of secretion of magnesium was very helpful, as well as the blood studies to find if they had hypokalemia or acidosis or hypomagnesemia and so forth. Regarding the genetic studies, which is very important, and I think if we repeat the study now or just few, we'll find the result is different. Because our study covered the last decade, the last 10 years, only 21 children had the positive results, and 11 of those were hyperoxaluria type 1, 3 children cystinuria, and 7 with familial hypoenzyemia hypercalciuric nephrocalcinosis, and all of them was Claudin 16. We did not have Claudin 19. So again, this is a repeat of the slide just to stress the importance that after imaging and in diagnosing case of stone, we need to find underlying the cause by doing urine studies to study the salts in the urine. Is it hyperoxaluria? Is it cystinuria? Is it hyperuricemia? Is it hypocysturia? Is it hypercalciuria? And then the blood test could help us a lot. Stone analysis can tell us a lot, and genetics is very important. What about the management of those children? We need to control the acute renal colic by using analgesia and hydration, recognition of the necessity of emergency intervention, and to facilitate the passage of the stone if it is possible, as it could happen in 50% of children, and in those less than 4 millimeter diameter of the stone. Alpha blocker and calcium channel blocker, it might facilitate the passage of the renal stone. Surgical management is required in 22% of the children within the first 6 months, and it could be in form of acute intervention and decompression, urethral stent, nephrostomy, shock-wave tripsy, or removal of the stone via urethoscopy. Prevention of the stone, further stones, very crucial. Fluid intake, plenty of fluid intake, 1.5 liter per meter square, and also dietary adjustment in form of adequate but not low calcium diet, as the low calcium diet will result in increase of calcium absorption and hypercalciuria. Also adequate but not excessive protein intake, as excessive protein intake will lead to hypercalciuria and hypocysturia, and low salt diet, as a high salt diet will result in hypercalciuria. So I will conclude my talk by saying that pediatric nephrolithiasis is different from adult. It is mainly caused by genetic and metabolic disorders, as metabolic cause is an important cause, and workup is recommended. Diagnostic facilities and abilities are improved in our kingdom. The aim of the treatment is to preserve the function of the kidney and to prevent the recurrence of the disease. Risk factors modification remain the basis for treatment of nephrolithiasis. I will stop here, and I'm happy to take any questions.
Thank you very much, Professor Jamila, for your elegant talk. I think we've got one question from Dr. Rpgn. Thank you, Prof, for your talk. My question is, do you recommend performing genetic tests to all young children presenting with renal stones with no obvious secondary etiology?
Yes, I think we do. I think I recommend that with after our first case of Sarah, and also I think we have to use all diagnostic modalities: urine studies, stone analysis, and genetics. And I think genetics is very important and tell us a lot.
Okay.
And this is our protocol in our unit.
So while waiting for further questions, I have one question, Prof. Jamila. While listening to your presentation, I've got the sense that the complex phenotype of nephrolithiasis is more common in our country than the idiopathic hypercalciuria, more of a simple urolithiasis. Do you think this is maybe related to referral bias, that this is, let's say, tertiary center? Do you think this sample represent what we have in the kingdom? Majority of our cases are complex genetic background, or do you think this is just because the type of population that you're seeing in your center?
If I understand your question, that the nephrolithiasis in children is mainly metabolic because we are a referral center. Is that
more of complex, genetic base? In your presentation, you've shown us a lot of cases where there is a positive gene background, and
I think in children, metabolic and genetic in all countries is more common than environmental factor. So it is the nephrolithiasis in children is different from adults. In adults, is mainly environmental. In children, is very metabolic, and it should be looked for in any country, not only in Saudi Arabia. But I have to say, for me, I came back from my fellowship and my life in the UK before 21 years. Our awareness as a pediatrician in the country, and also the referral is becoming more common. We recognize more cases of renal stones, and we have the abilities to diagnose those by sophisticated investigation. For instance, 15 years back, I didn't see those cases of renal stones. Nowadays, every week we have one case, almost every week.
Okay. So we have another question from Dr. Hala Shafi. What is the dose of Omnic to treat stone? I did not get the, what is the dose of Omnic to treat stone? Did you understand the question, Prof. Jamila?
No, I didn't.
If not, so we'll go to the second question.
Omnic is olmesartan. It's one of the alpha blockers.
Actually, no, I don't use it personally. Our colleague, the urologists, they use it.
Okay.
Yeah.
So there's a question from Dr. Muhammad Arshad. Nephrolithiasis can nephrolithiasis be managed by laser lithotripsy? I think also mainly a urology question.
Yes, it is. It depends on the size of the stone, and of course, it is a urology decision.
Yeah, Dr. Anud, if you allow me one question.
Sure.
Yeah. Thank you, Prof. Jamila. Very excellent and informative presentation. I think I totally agree with you that metabolic causes are more common than environmental causes in childhood age group. And I think it is more underestimated, especially the hyperoxaluria. We need to know that the access to the labs which can do the oxalate level in the serum and in the urine is not affordable to everyone. So I am sure that it is underestimated, the hyperoxaluria.
Yes, and also they come, I still remember some of cases apart from Sarah, they usually come to us quite late. So they come to us already, they're in the stage, even older children. So I have one child who actually had liver and kidney transplantation in America, and his sister was diagnosed early because of the history of her brother, but he came from the south at the age of 6 years with end-stage kidney disease. So they come quite late, and I agree with the Professor Saran. The only advantage we have now in our center, because we do it in our center, and I point to Dr. Muhammad Shalabi, Jazallah Khair. He worked hard to get all those facilities to our center, so we can do it now in our center, all urine studies. But when it comes to plasma with the rate, we have to send it abroad, actually, through private hospital. And genetics, it made all the difference. The ability to do genetics to most of the children, it made all the difference in the ability to diagnose those children.
I think we've got a few minutes for 2 more questions. We have Dr. Asma. If the child has family history of renal stone, but there is no signs or symptoms, how frequently the follow-up should be done?
There is no rules to that, but I would imagine if he does not have any symptoms, we just do the basic investigation, taking blood pressure, urine studies, because urine studies can tell you a lot. But I wouldn't recommend regular imaging for children who they do not have any symptoms.
All right, I think we don't have any further questions.
And there is Dr. Abdullah put in the chat one question. Right.
تفضل دكتور عبد المنعم.
Thank you, Prof. Jamila, for your great talk as usual. Just what is your experience with penicillamine for patients with synuria?
Yes, we have used it for older children with good success. Thiol, we have a problem in its availability. One of the parents, he gets it from Germany personally, and we got somebody who can get thiol for us. But penicillamine, we didn't use it except in older children with good success.
All right, I think we are approaching the end. Thank you very much, Professor Jamila, for your great talk and elegant presentation. And thanks for everyone, and thanks for the attending, for staying up until now. Thank you very much. يعطيكم العافية.
Thank you, Dr. Al-Anud. Thank you, Prof. Jamila. We will move on to the next talk. Dr. Abdullah Al-Harithi, if you can present, please, yourself and the speaker.
بسم الله الحمد لله والصلاة والسلام على رسول الله. First, I would like to thank the organizing committee and a special thanks to Professor Khalid Al-Sa'ran for inviting us for this excellent symposium. And we are very proud with this well organization and the attendance, walillahi alhamd. And also special thanks to Dr. Khalid Al-Hassan, the President of Saudi Society of Nephrology, for his hard work for continuing medical education in pediatric nephrology. Now, it gives me, I'm a pediatric nephrologist working in College of Medicine, Taif University. Now, it gives me a great pleasure to introduce our next speaker, Dr. Adi Al-Hirbish. And Dr. Adi, he's a consultant pediatric nephrology and kidney transplant, working at College of Medicine, King Saud University. He did his training in pediatric in Canada, and mashallah, he got his Canadian board and American board. And then he did also his pediatric nephrology fellowship in University of Alberta in Canada. And I am sure we will be interested in his talk about important topic in hyperoxaluria. And without further delay, I would welcome Dr. Adi. And Dr. Adi, the mic is yours.
Thank you, Prof. Abdullah. Is my slide appearing?
Yes. You can see it.
طيب, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. It's my pleasure to give this talk and to thank the Saudi Society of Nephrology and King Saud Medical City for arranging this fabulous conference. So after you heard the previous elegant talk by Prof. Jamila Qari about renal stones, I'm going to talk about the disease that we hate the most and that we are afraid to reach to a diagnosis the most, which is hyperoxaluria. And just to give you a flavor.
Dr. Adi, can you maximize your screen?
Is it okay now?
Yes.
Excellent. So just to give you a flavor of hyperoxaluria and how it can have different phenotypes, we're going to go over 3 very quick cases. So the first one is for a 6-year-old boy presented with acute onset flank pain and hematuria, had an ultrasound which showed an obstructive left distal ureteric stone, and also bilateral renal stones in the right and the left. His urine showed RBCs, calcium oxalate crystals, and a high urine oxalate creatinine ratio, and a normal calcium creatinine ratio. Renal function was normal. So because of high oxalate in the urine, gene studies was sent which showed a homozygous mutation in the gene encoding AGT. After reaching the diagnosis, the family declared an information that they were hiding of an uncle who had history of recurrent stone and who had a kidney transplantation without liver transplant, and he lost his kidney immediately after the transplantation, which is expected and unfortunate. So we increased the fluid intake for our child. We started him on potassium citrate, citric acid, and biodixin, and that was in 2020. So we Lumaziran was introduced, and we were trying to introduce it in our hospital. We negotiated with the pharmacy, but given the very high price of this medication with a vial costing 290,000 riyals, we failed, and we're still trying to find a way to arrange it for our patient. So second patient is a 3-month-old girl who was born outside Saudi Arabia and diagnosed there with chronic kidney disease stage 5, and she landed to our hospital after coming back to home. We arranged for her a Tinkoff catheter and started her on peritoneal dialysis, and kidney ultrasound showed nephrocalcinosis. So if you have nephrocalcinosis and chronic kidney disease, you are forced to check for hyperoxaluria, and as expected, she had a homozygous mutation for primary hyperoxaluria type 1. She continued into peritoneal dialysis until we did liver transplantation donated to her by her mother who had gestational diabetes. So we thought she's a better liver donor than a kidney donor. And then after we built up her weight and continued her on hemodialysis until she reached 9 to 10 kilograms, she had kidney from her father, and currently she has stable graft with very normal creatinine. Case 3 is less fortunate, a 13-year-old boy who came with fatigability and pallor, and he has a sister known to have primary hyperoxaluria type 1 who had a liver transplantation, and she is on hemodialysis. Father also had end-stage renal disease and was on hemodialysis, but never had a genetic testing. And father died young, so the mother was single mother taking care after these highly demanding children. It was a very, very difficult social situation, and on top of that, the nephrology team comes and give her this news and tell her we need to do hemodialysis on daily basis. He was started in the hemodialysis, but as expected, he was not very compliant. We tried to enlist him for combined liver and kidney transplantation, but in Saudi Arabia, the disease donor donation is very slow. So with time, unfortunately, he started to develop symptoms of systemic oxalosis with generalized bone pain until he became wheelchair bound. So these 3 cases show you that hyperoxaluria, if delayed, can lead to serious disease, which is oxalosis, and it can also present as infantile disease or as recurrent kidney stone. As you know, primary hyperoxaluria is an inborn error of metabolism in the glyoxalate, and the glyoxalate get detoxified and converted to glycine in the peroxisome by alanine glyoxalate aminotransferase. If there is a mutation in this enzyme, then glyoxalate will accumulate and glycolate, and glyoxalate will be converted by LDH to oxalate, which will cause the disease. If you have deficiency in glyoxylate reductase hydroxypyruvate reductase, then you will have accumulation of glyoxylate leading to increased oxalate and accumulation of L-glycerate because hydroxypyruvate cannot be converted to D-glycerate. And in type 3, you have a problem in the hydroxyoxoglutarate aldolase. So if this substrate cannot be converted to pyruvate and glycolate, it gets out of the mitochondria and there get converted to oxalate without being able to enter the peroxisome and get detoxified and result in oxalosis. So as you know, type 1 is the most serious and the most common. It leads in most of the cases to end-stage renal disease. In some cases, it can respond to biodixin, but in type 2 and type 3, they don't respond to biodixin. Type 2 end-stage renal disease can happen, but less frequent than type 1. And type 3, we used to think about it as just mild disease with recurrent kidney stones. But as I will show you, it can result also in chronic kidney disease. This is a very nice cartoon that shows you in hyperoxaluria, if you have increased production of oxalate, the oxalate will form oxalate crystals, which give you this calcium oxalate monohydrate dumbbell-like picture, which is typical of it. And they can give you brown, very hard stones. If the GFR decreases below 40 ml per minute per 1.73, then the oxalate will exceed its threshold, supersaturation threshold, and start to precipitate in the tissues, resulting in nephrocalcinosis and starting to precipitate in bone, heart, tissues, blood. And when you start dialysis, even if you do significant dialysis, you will not be able to handle and remove all the oxalate which is produced. And this was examined in the 90s. Like in this study, they took patients with oxalosis and patients on dialysis without oxalosis and checked the oxalate generation that they have. So if they don't have primary oxalosis, they produce 0.2 millimole per 1.73 per day. But if they have oxalosis, they produce from 4 to 6 millimole per day. In single hemodialysis session, you remove 2 to 2.8 millimole per day. So as you can see, even in the day you do hemodialysis, you will end up with significant positive balance of oxalate that you cannot remove. So this shows you, obviously, if you do intermittent hemodialysis, you will be lagging much, much behind. And even if you do daily hemodialysis, you will be behind. And when oxalates start to precipitate, it can precipitate in the bones. Like here, you can see these sclerotic bands, and it can lead to vertebral fractures and kyphosis. And here in this child, you can see precipitation in the spleen causing splenomegaly and in the skin causing calciphylaxis. It can also precipitate in the retina, thyroid causing hypothyroidism, bones, arteries, nerves, muscles, bowels, everywhere. So as I said before, we used to think that hyperoxaluria is recurrent stone disease, not affecting the GFR. But this is probably the biggest study that examined patients with type 3 hyperoxaluria. It's from the Oxalate European Registry. They collected 95 patients and had 49 patients from the German Hyperoxalate Center. And as you can see, majority of patients had early presentation below 4 years of age. And most of them had recurrent stones, urolithiasis. Some of them had nephrocalcinosis, but it's a very small percentage. And some had UTI. And as you can see here, 50% had chronic kidney disease stage 1, 15% stage 2, and 3.8% stage 3. They are having urine oxalate, which is comparable to type 1 and 2 in amount. And what is surprising that the urine calcium creatinine ratio was normal. We used to think that there will be hypercalciuria, but this is not true in this series. And here they compared the urine oxalate and plasma oxalate in type 3 to type 2 and type 1, which is pyridoxine responsive and pyridoxine irresponsive. And you can see here, all of them had a similar urine oxalate level, although those with type 1 who are pyridoxine responsive had the lowest level. And here you can see that the highest plasma oxalate level is in primary hyperoxaluria type 1, which is pyridoxine irresponsive, but the remaining are comparable. Previously, and probably we're still depending on the guidelines done by Dr. Koshat and group, which were published in 2012, they recommended to screen and diagnose primary hyperoxaluria in any children with kidney stones and children with nephrocalcinosis, especially that if they had decreased GFR, in patients with oxalate crystals, and to screen relatives of index cases. When you quantify oxalate, do 24-hour urine if possible. If it's not possible, you can do the oxalate creatinine ratio, but you need to review what is the normal for each age group. Sometimes doing plasma oxalate in those with decreased GFR could be helpful, especially if it's above 100 micromole per liter. Measurement of AGT enzyme activity as a practice has decreased significantly with the advance of genetic techniques. They recommended doing fundoscopy when GFR below 60, ECG, echocardiography, and bone X-ray when GFR below 30, and to start conservative therapy, which is hyperhydration with fluid intake more than 3 liters per 1.73 per square meter per day. High dose pyridoxine, 5 to 20 milligram per kg. You can give it a try for 3 months and then check the response. If the reduction in urine oxalate more than 30%, then you will continue on this. If not, then you will discontinue it. And to use inhibitors of crystallization like potassium citrate and magnesium oxide. Don't do surgical intervention unless there is obstruction. Then it's better to do it by endoscopic procedure. Lithotripsy is not recommended because with all the nephrocalcinosis in the kidney, it will cause damage to the kidney. Dialysis, as we saw before, that the dialysis, even if it's daily, you will end up with positive oxalate balance. So you need to do very high efficiency dialysis with nocturnal dialysis or daily hemodialysis, or 6 times per week at least. And sometimes if there's significant oxalate deposition around the time of transplantation, you need to do hemodialysis, hemofiltration. And when planning for transplantation, you need to start planning it when GFR below 40. And when you do the transplantation, it's better to be combined or sequential liver kidney transplantation. So this is a systematic review which checked the different modalities of transplantation in primary hyperoxaluria type 1. They screened 554 studies and ended with 51 studies. And when they compared combined liver and kidney transplantation to kidney transplantation alone, you can see that most of the studies showed better graft survival in the combined kidney and liver as compared to kidney alone. Here, when you look at the patient survival, in one of these studies, you can see that the patient survival in the kidney alone was higher than the combined kidney and liver. And probably that's not surprising 10 years ago. And now with the advance of liver transplantation, probably these numbers are not true anymore. And when you do death-censored graft survival, you will find there is significant advantage in terms of kidney graft survival if you do combined kidney and liver. When they looked at comparing combined liver and kidney to sequential liver and kidney, basically there were no big differences between the two. So despite recommending against doing kidney-only transplantation, there are certain people who did this, especially if you have a mutation, which is a mild mutation called G170R, which is a mistargeting mutation. The AGT will be functioning, but in the mitochondria rather than in the peroxisome. So these patients usually respond to Biopsy. And because of this, this group transplanted 5 patients with primary hyperoxaluria type 1 caused by this mutation with kidney only and good doses of pyridoxine. They had good graft survival in 4 of their patients, but 1 of them lost the kidney after metabolic decompensation and surge in the urine oxalate. So not totally safe practice. I'm sure you heard about Oxalobacter formigenes as a way to decrease oxalate, and it comes in a lot of the reviews of systemic oxalosis and primary hyperoxaluria. But when you look at the best evidence that we have, which is randomized controlled trials, they randomized patients into taking this bacteria or taking placebo, and there was no significant reduction in the urine oxalate between the group who took the medicine and the group who took the placebo. So really not that useful. The drug that changed and will change our practice for primary hyperoxaluria is lumasiran. Lumasiran is an RNA interfering drug. If you remember, we said if you have mutation in AGT, there will be accumulation of glyoxylate, which will be converted by LDH to oxalate. So what will happen if you inhibit the glycolate oxidase, then you will have less glyoxylate. And this is what lumasiran do. I'm sure most of you or all of you are familiar with the New England paper, which was published in 2021. They randomized patients with primary hyperoxaluria type 1 to have lumasiran or placebo. And if you look at the characteristics, they were the same in terms of age, race, geographic region, biodixin, the level of plasma oxalate and GFR. And then when they looked at the primary outcome, there was significant statistical and clinical drop in the urine oxalate in the group who received lumasiran. And you can see this after 3 doses, after finishing the loading dose. And then they were able to keep the urine oxalate doses in a range near the 0.5 millimole per 1.73 per day. And you can see this effect also in the plasma oxalate. The medication was quite safe. The only probably significant side effect was injection site reaction, which can happen with these types of medications. But there was no mortality, no serious adverse effect. So the other medication that is examined is, and lumasiran, as you know, it's FDA approved and started to be used, but because of its very expensive, it's very hard to get it for your patients. Nedosiran still under clinical trials. The idea of it is to interfere with the LDH, which convert glyoxylate into oxalate. And they thought this will be the magic answer for all types of primary hyperoxaluria, because you're interfering with LDH that convert glyoxylate to oxalate. They were worried that if they interfered with lactate dehydrogenase, which is present in the muscles, that they will cause significant side effects. But when they looked at the clinical symptomatology of those with lactate dehydrogenase A deficiency and mutations, they found that they are basically asymptomatic. The only thing that they will have a surge in plasma pyruvate and creatine kinase if they do vigorous exercise. So because of this, they started the trials using Nedosiran. They started with safety trials and used it in the primary hyperoxaluria groups, type 1 and 2, and there were no serious side effects. And here in a poster published in the latest ASN meeting in 2021, you can see that they recruited patients who are older than 6 years of age with primary hyperoxaluria type 1 and 2, and with an GFR above 30, and examined the response in the 24-hour urine exhalate. And you can see here that there was a very good response in patients with primary hyperoxaluria type 1 to Nedosiran, but which was surprising and disappointing that patients with primary hyperoxaluria type 2, they didn't respond like primary hyperoxaluria type 1. So probably the oxalative reduction in type 2 is more complicated than what we thought. Just to understand how these medications are revolutionary and can change our practice, this is a case report of a patient who was diagnosed with primary hyperoxaluria when she was 5 years of age. And then when she was 17, she developed end-stage renal disease. Her brother had same disease and had combined liver and kidney transplantation. She was enlisted in the waiting list for liver and kidney transplantation, but she didn't get it and started on intensive hemodialysis 6 times per week. And then they asked to get Nedosiran in compassionate care program. And she started it in July in monthly basis. As you can see, the plasma oxalate decreased below the threshold of 15, which is safe for transplantation. And they were able to decrease hemodialysis from 6 times weekly to 3 times weekly with a pre-hemodialysis plasma oxalate still below the 15. And you can see here the nice decrease in plasma oxalate after starting the medication to a degree that when they had an offer for combined kidney and liver transplantation, they declined the offer. So if we are able to achieve this, and if the Nedosiran in the future will be affordable and there, probably it will, with Lumasiran, be the practice and replace liver transplantation as a way to fix the problem with AGT. And this is a very nice review paper which check this and see how these medication will change our practice. So in terms of transplantation strategies, they think if we had this medication readily available, affordable, and available to all our patients, which is not in the near future, then if you had a patient with an estimated GFR above 30, you will put the patient on RNA intervening drug and follow his kidney function. And that's it. If you have patients on hemodialysis, then you will put the patient on Lumasiran or Nedosiran. Continue your hemodialysis until you get rid of all the oxalate pool in the body. And then when the plasma oxalate below 20, then you can go for kidney transplantation without the need to do a liver transplant. And in those who are between 15 and 30, you can start the medication and then assess your oxalate deposition stores. If they are high, then you will delay the transplantation. If they are not, then you will go for kidney transplantation. So in conclusion, primary hyperoxaluria is a serious disease with devastating consequences. It should be suspected and screened for in any child with urolithiasis, nephrocalcinosis, calcium oxalate crystals, and in relatives of index cases. If urine oxalate is high, please start conservative therapy immediately, and you have to send for genetic testing. Until RNA interfering drugs become readily available and affordable, liver transplantation will continue to be the only way to replace non-functional or deficient AGT-associated oxalosis. Lumasiran and Nidoziran are revolutionary and might change our approach to primary hyperoxaluria. This practice change might be hindered by the problems of affordability and availability. Thank you very much.
Thank you very much, Dr. Adi, for this excellent and comprehensive talk about the hyperoxaluria and the updated knowledge about the new medication. While I will receive the questions from the audience, Dr. Adaya, I would like to ask you kindly if you have crossed about the age of limitation between both Lumasiran and Nidoziran and the duration. Is it extended more than 6 months or less than this? Do you have cross this information about both medication?
When you use it, unfortunately, you will depend on the age they choose it as an inclusion criteria. And here it was above 6 years of age.
6 years.
Yes. That's the age they choose in the paper in the study they designed, and that's what we will depend on. Now, in Lumasiran, for example, you will give 3 doses as a loading dose, and then it will be given every 3 months through subcutaneous route. Its problem is it needs to be continued. If you discontinue, then the patient will return to producing the oxalate and you will lag behind him. So expensive medication might be a medication for life. We will have the same problem like eculizumab in HUS.
Okay. I have one question here in the chat. Thanks, Dr. Adey. And any recommendation for combined liver kidney transplant in patients with hyperoxaluria and sickle cell disease, as they tend to have thrombosis due to hyperviscosity in case of crisis? I hope is it clear for you, Dr. Adey?
Well, just having primary hyperoxaluria type 1 by itself, if you're gonna go kidney transplantation, as I explained before, you have to go for a combined kidney and liver and kidney transplantation. Would you do it in the same time or sequential? It depends on your transplantation program and whether it's disease donor oriented or living related oriented, and whether you have 2 donors or one donor. But primary oxaluria means you have 2 organs, unfortunately, until we have these medications which will cause us to start them and then to do kidney transplantation if you have end-stage renal disease.
Now I have several questions asking the same things. Why is not available in MOH hospital? And I think this is something probably out of our...
So very good question, because this is a medication. If you have it, you will avoid major organ transplantation.
Yes.
So we wish it and we have to fight to get it for our patients. The problem, they just finished the study and had it for our patients, but the vial, for 1 dose, you will pay for it 290,000. So to give a loading dose, it means you will give 890,000, near 1 million. Can your hospital afford this? No, this is something needs to be done in country-wide approach, and be covered with the biological and these medications. It's going to be very tough and challenging thing, but we have, as advocate for our patients, to fight for it.
Could you allow me for one question, Dr. Abdullah?
Yes, please, please.
Thank you, Dr. Adi. Very phenomenal presentation. I enjoyed every single slide that you presented. Just a question, probably Dr. Abdullah didn't formalize it. My question is sickle cell disease by itself a contraindication for kidney or combined kidney liver transplant in patients with hyperoxaluria?
I don't think so. You can go if the patient is the recipient, you can go for the transplantation. Now
we had a patient and they refused. They said that patients with sickle cell disease tend to have hyperviscosity and crisis, and they may have thrombosis
in the liver.
Exactly.
That's a serious and reasonable concern. I need to hear the thinking of the hepatic surgeon and our hepatology colleagues, but it can happen. You can have problem with the anastomosis, and if you have on top of this oxalosis and all the oxalate which is deposited in the pool moving to your anastomosis site, then you might have a thrombosis. Does this preclude the diagnosis, or should this patient have intensive dialysis before and after and then try to attempt it? I'm not sure. We can argue about that.
There is a question here. They said, will early liver transplant prevent the need for kidney transplant for patients with hyperoxaluria?
This is a very interesting question because when you have a patient with completely normal kidney function, can you convince the hepatologist and convince yourself and the patient to go for liver transplantation when his liver function is completely normal but just deficient in AGT? That's why when I showed you the European guidelines, probably I jumped over it. They didn't advise to do that, but in certain cases you need to consider it. For example, if you have a patient with pyridoxine non-responding disease who has deteriorating GFR, and you know that the disease donor program in our country, especially if he's O group, is very slow and he might not get a chance to have combined kidney and liver. And you know that maybe he has only one donor who, if he donates the liver, will not be able to donate kidney in the future. In a stage like this, you might consider doing liver transplantation before having deterioration in the kidney. But it's not a very common practice.
Prof. Abdullah, I think we need to stop here.
Okay, so
thank you, Prof. Abdullah. Thank you, Dr. Adi. And we will move now to the last, but not the least, presentation for this symposium. Dr. Turkish Sharif, please present yourself and the speaker.
Good evening, everyone, and this is Turkish Sharif, pediatric nephrologist from King Faisal Specialist Hospital and Research Center here in Riyadh. At the beginning, I would like to thank the organizing committee for inviting us to this excellent meeting, and which has been special thank to Prof. Khalid Sa'ran and Dr. Khalid Al-Hassan, the president of the Saudi Society of Nephrology. And as you can see, actually, this is the last session, and I will not hold you even further from the great talk that we are looking for by Dr. Prof. Dieter Hafner. He is the head of the Department of Kidney, Liver and Metabolic Disease, and the director of Kidney Center for Children and Adolescents at Hanover. Dr. Hafner has published more than 200 original scientific article reviews and clinical practice guidelines. He's well known in the field of nephrology. He has supervised more than 30 MD and PhD students, and he has awarded more than 20 research grants. It's actually a pleasure to have him with us tonight. He's going to talk to us about the recombinant growth hormone for patients with renal disease. What is the evidence? Please, Dr. Dieter, the floor is yours.
Thank you very much for your kind introduction. I'm delighted to speak here. I would even be more delighted to be with you in your beautiful country. So the sun is just dropping down here and it's getting cold. We expect about -1 degree tonight, which is, I think, a little bit different in your country. So I will talk about growth hormone, and I will especially point out a clinical practice guideline about that. So to start with, I would like to start with an example here. Sorry, I just have to adapt my computer. Now it works. No. Yeah, now it's good. I couldn't see my slides. Okay, so attainment of a normal adult height is a great challenge in children with chronic kidney disease, and this could not be better explained like examples given here from 3 pairs of sicklings I was taking care of the last 20 years. And actually this little girl presented with end-stage kidney disease. It was unknown. You see the renal osteodystrophy, so there was an orthopedic surgeon who looked at it and said, well, it's leg bowing, it would be fine. However, this girl presented with end-stage kidney disease to us. She had a hypocalcemia and tetany. So you see the height difference is about 15 centimeter. It's more or less the same here as with this younger girl together in comparison with her brother. Is about 15 centimeters. So this is really a major challenge. Children with congenital kidney disease have the greatest problem because they usually suffer from growth failure in early life, so that get growth retarded until school age. Usually there's a percentile parallel growth in school age, and later during adolescence, they usually present with a delayed and reduced pubertal growth spurt. So we have 3 periods, and we assume that the first period in early life is more or less the growth driven by nutrition. Later on, it's mainly driven by growth hormone, and then during puberty, as you know, it's the concert between sex hormones and growth hormone. In the first years of life, height velocity is highest. So it's expected that a healthy child has an increase in height of about 50 centimeter during the first 3 years of life. So you can expect if a child is not growing well, this has major effects on his height. And children on dialysis may have a loss of height of about 1 SD score within 3 months. A little bit less severe period is puberty. In puberty, in boys, it's about expected a height gain of about 30 centimeter, and in girls about 25 centimeter. So this is also a vulnerable period. When we go back and look at the growth chart of this patient here, I mentioned that its growth is parallel to the percentiles. However, this should be assumed to be pathologic, since the child is growth retarded, and according to Tanner, this child should have catch-up growth. So the percentile parallel growth is abnormal. Well, the good news, height improved in patients requiring kidney replacement therapy. These are data from the ESPN EIA-TTA registry, and as you can see, that height standard deviation score improved during last decades. However, it's still around -2 standard deviations for children who are very young when they when they required kidney replacement therapy. So what do we know about the pathology? It's quite easy. It starts already in utero. So children with chronic kidney disease has very often intrauterine growth retardation. And this is thought that it may also promote chronic kidney disease. And on the other side, chronic kidney disease may also promote intravenous growth retardation and prematurity. So especially children with CACUD, they have a poor start in life because they are already short when they come to birth. In the first year of life, nutrition is extremely important. And children with advanced kidney disease are prone to malnutrition. They don't have appetite, they are vomiting. If they are on dialysis, they have dialysis fluid in the belly. So it's a great problem. However, we have also the consequences of mineral and bone disorders in children with chronic kidney disease. And here the most important is severe hypothyroidism. So if you have uncontrolled hypothyroidism, it's also not good for the growth. Then we have metabolic acidosis, which is an important matter. Renal anemia, yes, it also contributes a little bit to that. However, if you take care of nutrition, you take care of CKD, MVD, you do correct metabolic acidosis and renal anemia, there are many children who are still not growing very well or who are not showing catch-up growth. And when people measured growth hormone in the early studies, they realized that usually the growth hormone levels are normal. However, the growth hormone receptor in target organs, as well as the signaling process, which is characterized by activation of the CHEK2-STAT5 signaling, is impaired in the target organs, in the liver, which is responsible to produce circulating IGF-1, the somatotropin, which mediates the growth-promoting effects of growth hormone, and also in the growth cartilage, when this we need to grow. And it's not well known how this works, but there are experimental studies showing that inflammation is also causing the growth hormone resistance, or what we say growth hormone insensitivity. So we have a problem in the somatotropic hormone axis, but we also have a problem in the gonadotropic hormone axis, which usually becomes clinical prevalent in patients on long-standing dialysis. They have a problem with the gonadotropin releasing hormone pulse generator. They have probably low levels of lutein hormone. And in the end, they have low sex hormone levels, which result in a pubertal delay and hypogonadism. So if you treat children with chronic kidney disease who are short with recombinant human growth hormone, it rapidly normalizes the IGF bioactivity and it increases the serum levels of IGF-1. And you see that expected usually that the IGF-1 levels are in the upper normal range if you treat the child. We don't measure those levels during treatment, but it's a good measure to assess adherence. So if you have a patient who starts with a low IGF-1 and you treat the patient, or the patient is assumed to get his injection, and the IGF-1 levels don't go up, it's probably a problem of non-adherence. So how does it work? This is the first patient we treated in Heidelberg. He was started in '86. He was started when I just started as a young doctor in Heidelberg, and you can see that his height markedly improved despite that he required dialysis. But we also see, well, there's something going on here. So we were a little bit puzzled and thought, well, what was going here? And this is just the prepubertal dip, the physiological prepubertal dip, which just occurs later than expected because the patient had also delayed pubertal growth spurt. So if you're a prepubertal patient and the height velocity goes down and you just need to wait until puberty starts and the sexual development starts, and then you get a nice pubertal growth spurt. What are the effects? If you talk to the parents and the patient, they have expectations. They look at me, I'm almost 190 centimeter tall, then they think they get tall as I am. But this is not true, so you have to tell them the truth. So the height gain in our trial for the height improvement for boys amounted about 10.5 centimeter, which was reflected just to 1.5 standard deviation score for the for the boys, and 1.4 SDS, which reflects to 7 centimeters in girls. So this is expected. However, you also have to take into account what will happen if you don't treat them with growth hormone. So in those patients, it's usually expected that they have a little loss of standardized height. So actually the netto effect, I always tell boys about 12 centimeters and girls about 9 centimeters. So that's what is in the average expected, what they can expect with the treatment. When we started with the trial, the patients were around 10 years of age, and then it was licensed, the growth hormone treatment. And then everybody thought, well, in the first year of life, it doesn't make sense to treat children with growth hormone because in the textbook, it's written that growth in the first year of life mainly or more almostly exclusively depends on nutrition. So there are smart people around in the world, especially in Oviedo in Spain. Professor Fernando Santos challenged this hypothesis, and he organized randomized controlled trials with children who were well nourished, they had good nutrition intake, and were growth retarded, and they had the GFR between 50 and 60. And here you can see that the standardized height extremely nicely improved. It improved within 12 months by 1.5 standard deviation score, which was in the end the same as we in our trial with the older patient could achieve within 5 years. It made this in 1 year. So we were a little bit puzzled, what is it all about? This has to do something with mathematics. When we looked in our trial, we observed that the delta change in growth rate is independent of age. So if a child is 1 year old or 8 year old, they always gain 4.9 centimeter more than on baseline. And if you add this during the subsequent years, you see that the younger child rapidly comes into the normal range, whereas an older child still is below the normal range. And this is also due to the fact that the range of the growth chart, so that between the 3rd and the 97th percentile, is widening with age. So this makes sense. This is the consequence of that, is to start early. If you want to that the child is getting into the normal range, you need to start early. Don't discuss 1 year and say, well, we may wait a year. No, if you start early. Then we come to the sad news. The sad news is if a patient is already on dialysis, he or she is also growing better, but this doesn't compare to children who have chronic kidney disease stage 3 or 4, because they have usually a height gain within 2 years of only 0.5 standard deviation scores, where the others usually have a height gain of more than 1 standard deviation score. So if you want to start growth hormone, if possible, start it before the patient is started on dialysis. So we now come to the clinical practice recommendation. It's published as an open access, and I would just summarize the most important recommendations. First, a little bit to the grading matrix we used. We used the grading matrix from the American Academy of Pediatrics, which is very easy to use. So usually, if there's a high-level randomized trials, we have a high evidence, then we have a strong or moderate recommendation. And this we recommend. If there's only a weak recommendation, we use the term suggest. So if you later on see the word we recommend, then you know it's a strong or moderate recommendation. And if you read the term suggest, then we always know it's a weak recommendation. So first, of course, you have to check what is going on with the height and length in younger children. And this, of course, depends on age and stage of CKD. I will show you the table in a few seconds. And then you need to calculate height velocity. And to do so, you need a minimum period of 6 months. And of course, you have to plot everything on standardized growth chart. And for example, here, if you have a child age more than 3 years and a CKD stage 3, it may be fine to check height every 3 up to 6 months. However, if you have more advanced CKD, and especially in young children, you need to do this every 4 weeks. So, and then we have to check the growth potential. And we do not recommend to use height prediction methods, for example, assessing bone age and look with the Greulich and Pyle method or the Tanner method, they always overpredict height, and they are really not recommended. So what instead we suggest to check for the genetic target height, according to the Tanner formula or the Molinari formula, which is also appreciating the secular trend. And then we have always to look if the epiphyses are open. This doesn't be a problem in children with 10 or 11 years old, but sometimes even if the child are 15 years old, sometimes the epiphyses are already closed. So it's good to check this before considering growth hormone treatment. And then of course, age we have to consider. I just told you younger children will respond better. Primary renal disease, you have to check if there's systemic disorder. And then of course you have to check if there's adequate dialysis, and patients who are transplanted, you have to consider the graft function together with glucocorticoid therapy. I will come back to the glucocorticoid therapy in a few minutes. So before considering growth hormone, you must make sure that you do your treatment in a proper way with respect to the growth limiting factors. I just showed you the cartoon. There's also a box 2 in the publication where we have a long list where you just go through to check everything that you are doing right. First, of course, especially in young children, you have to check that the protein and the caloric intake is okay. Some children may need tube feeding. You have to correct metabolic acidosis, hyponatremia, dehydration. Severe secondary hyperthyroidism is especially important. So this has to be checked first. And before we start with growth hormone, you of course have to check the lab values for mineral metabolism, including vitamin D. And since there is a small risk to develop diabetes with growth hormone, you have to check, of course, fasting glucose and HbA1c levels. Some children may have, in addition, hypothyroidism. So this has to be checked. And as I told you before, we check IGF-1 levels. There's no limit. Usually the limit, they are low, but we use them to check adherence while on treatment. And then it's worth to do a fundoscopic examination because there's a small risk for children on growth hormone to get intracranial hypertension. So you have to check if there's something wrong in the fundoscopy because later on you may compare this if the child has presentation, for example, with headache or something. And then you do the radiography of the left wrist, basically not so much to check bone age, but rather to check if the epiphyses are open, and especially in patients of pubertal age, of course, you have to check the pubertal status. Well, and you have to discuss openly with the parents and the child what is expected. I just told you the 12 and the 9 centimeters for boys and girls. And you have to, of course, check if the patients are immobilized or if they are syndromic kidney disease. You really have to check if the patients will benefit on height gain. And then based on the randomized trials and the final height data we achieved, we summarized 3 major statements on the indication of growth hormone. And I just want to highlight, if a patient is growth retarded and has a CKD stage 1 or 2, there's nothing about a deficit or growth hormone resistance. If they don't grow, there's something different wrong. They may have a syndromic disease. They may have metabolic acidosis, or a girl, for example, may have Ulrich-Turner syndrome. So this has to be rather checked by the endocrinologist and not just started with growth hormone. However, if a patient has CKD stage 3 up to 5 or on dialysis, aged above 6 months, should be candidates if the patients have persistent growth failure, and this is quite easy to find. So the patient is short, height below the 3rd percentile, and he's growing slowly. That means below the 25th percentile. If the patient is growing at the 50th percentile and has a height below the 3rd percentile, they will have usually a slow catch-up growth. So you have to make sure this. And of course, you have to check that other potential treatable risk factors for growth failure are adequately addressed, like I showed you before. However, there are some patients who are around the 3rd and 10th percentile, and we feel this is a weak recommendation. If they have persistent growth failure, they may also be candidates if they have advanced chronic kidney disease. There's only one, and now we come to the transplant, sorry. In the transplant patients, we usually don't give growth hormone in the first year after transplantation because they're expected to have catch-up growth after transplantation. And if the patient is not growing well, we first feel we should consider if there's a way for steroid-free immunosuppression, because then the patient has a nice opportunity to show catch-up growth. However, if the patient is not showing catch-up growth, is growth retarded, it's the same audiological criteria I just told you, and it's 1 year after transplantation, you may also consider growth hormone. In children with nephropathic cystinosis, they are extremely prone for growth failure. And in this, we made studies, it was mainly done by Elke Bühl in Heidelberg, where she demonstrated that those children, even if they have a GFR above 60, they really benefit from growth hormone. So for these patients, we do not give a limit for CKD stage. We just say every patient with nephropathic cystinosis showing persistent growth failure should be a candidate. However, there are some contraindications. Of course, if the epiphyses are closed, if the patient is unwilling, if the patient has severe secondary hyperthyroidism, you first have to correct it. If it's the first year after kidney transplantation, or if patients have acute critical illness. This is very important also during the treatment later on, because there was some randomized trial where the people thought that it may be beneficial in critical care patients with sepsis, for example, to treat them with growth hormone, but they have a poor outcome. So if a patient's on growth hormone and gets sepsis or something else, always stop growth hormone. And then, of course, patients with active malignancy, not with cured malignancy, but with active malignancy, they should also not be treated. So the dosage is quite clear. It's one dosage. There's no way to increase the dosage. It's supraphysiological dosage. It's about double dosage than we use for children with growth hormone deficiency. And we just adjust this according to body weight, and it's giving in the evening to mimic a little bit the physiological increase in growth hormone secretion in healthy children. And what we really encourage, and we feel that it's good for the children, for their self-esteem, to encourage them to do their injection by themselves. So they don't need the parent. And this is always, at least we try this if the child's older than 8 or 10 years of age. Most of our children, in our experience, like it, and it's good for their self-esteem. Of course, you have to monitor it every 3 to 6 months. You have to check height, velocity, pubertal development, thyroid hormone levels every year. And you have to occasionally look for glucose. And of course, you have to check the parameters of mineral metabolism. The side effect profile is quite good for growth hormone. So there's no increased risk for rejection episodes after transplantation malignancy. However, growth hormone promotes insulin resistance, which is usually not a problem. However, in patients with nephropathic cystinosis, this may be a problem because they are already prone to get this. Secondary hyperthyroidism may progress, so it's always a problem, as you know, from adherence. So if the PTH goes up, you may stop growth hormone for a short period and make sure that the patient's taking his drugs with respect to phosphate binders and active vitamin D. Hypothyroidism may occur, you check this yearly, and the only clinical problem we will may occur is benign intracranial hypertension. It's important to tell the parents and the child that this may happen. So if the patient has a persistent headache, you should always go for fundoscopy. And if there's benign intracranial hypertension, then you usually stop growth hormone. You may reintroduce it, but at least 50% of patients get a relapse of intracranial hypertension. So what is expected? What do we feel is a good growth response? So in the randomized trial, the height velocity change compared to baseline was roughly about 4 centimeters, and you see the 95% confidence interval was between 3 and 4.4. So we considered in our guideline that patients who who are gaining less than 2 centimeters plus in height velocity over baseline, they should be checked. Of course, it's adherence, and then we can check the IGF-1 levels. We have to check that the dosage is fine. And of course, you have to check nutrition and metabolic factors. I never saw a patient who was growing less than 2 centimeters per year expect one patient who was just injecting his growth hormone into his pillow together with the erythropoietin. Otherwise, all the parents, were growing better. So we recommend stopping growth hormone if there is epiphyseal closure. At the time of kidney transplantation, if the patient show severe hypothyroidism, this may be reintroduced after the PTH levels went into normal range. And as I told you before, if the patients have intracranial hypertension. And then there's also a rather rare complication, but which could happen especially in obese pubertal patients. It's slipped capital femoral epiphysis, especially those with severe hypothyroidism. And this is also the cause why we recommend to stop growth hormone in patients with severe hypothyroidism, because this is a risk factor for capital femoral epiphysis. And then, of course, if the patient does not adequately respond to growth hormone despite optimal nutrition and metabolic control, this is major also with non-adherence. And we wrote this down. I never observed it, but of course, we check bone age every year. And if the patient has really accelerated bone maturation, you may consider to stop it. So then is always the question, when to stop? Well, if the patient reaches genetic target height percentile, so his height percentile is the 50th percentile, is in there, you may stop this, but you may have to know that about 50% of patients show catch down growth and you need to reinstitute it. I usually continue it, and I usually continue it until the patient reaches his genetic target height or is getting adult height. So I was very quick because I was sure that your symposium should be finished now. And to summarize this, if you have growth hormone available, it's not a cheap drug, but if you have available, I recommend to be proactive, not discuss half a year or 1 year. It's more effective if you start early growth hormone. So use it proactively, but it's complementary to what we do with all our other medications, with nutrition, with dialysis adequacy. So it's in the concert what we do. And I usually, if the patient have starting with to show up with growth problems, I usually start the discussion early with the parents. And we even treat, it's not many children, but we even treat also infants who are not well growing. And for those children, we have the feeling if they have better catch-up growth, we can transplant them earlier because they are better gaining weight. And if they have a very small child and the father or mother wants to spend the kidney, it's maybe good if they show catch-up growth, because life on peritoneal dialysis is not easy for the parents, for the children, and us. We are keeping for them, taking care. So this is my home message. So normal adult height in children is a real challenge, but it's not a miracle. And with that, I would like to thank you for your attention. So this is a picture from Hanover, from our castle, which was recently renovated. And I thank you for attention, and I'm happy to take your questions.
Thank you very much, Prof. Hanan. This is a wonderful talk. We enjoyed every single of it, actually. And this, like we, as you have mentioned, that and you scared us actually when you show us the German team, football team, at the end of the slide. So because, like, we will see the German teams at the World Club soon, inshallah. Our national team will meet. There is actually a question from Dr. Ibrahim Sandakji about like if we can only give growth hormone for a limited time for social or financial reasons, which age you will best expect the best response to
prepubertal and prepubertal. So if you have a child which is if you have limited resources and the child is very growth retarded and you have a GFR of 30, I would, and you could just give it 1 year, I would give it immediately. I would not wait 2 years, because then you have the best growth response. So if the child is younger and the GFR is higher, usually you have the best growth response. However, if the GFR is 60, I would first check is something, well, what about nutrition? But if the patient has advanced CKD and you have the opportunity to treat the child for 1 or 2 years, I would not wait. I just would give the 2 years for catch-up growth, and then usually they should grow in parallel. If you wait until they are on dialysis or in puberty, the costs are much higher because it's weight related. So if a child is 20 kilogram or 40 kilogram, it's a double cost. So if you have it available, do it early.
Thank you very much. There is another question about when to stop it in regard to the target PTH. It seems that 500 sometimes is very difficult to achieve in some of the patients. So and to keep the BTH, so will you stop it every now and then? And what is the best approach to just run between these two? Yeah.
Every Tuesday we have the ward round on the hemodialysis ward, and it's always the same discussion. It's about phosphate of 2.7 millimole and the PTH, which has 600 or something. So what we first do, we discuss this openly with the patient and the parents and say, well, you now have to take your drugs. And if it does not work, then we may consider stopping it. And usually the patients are very keen to get the growth hormone. So it's also the way to give a little pressure on them. So if they have persistence levels of higher than 500, and this usually also indicates they are non-compliant, and then sometimes we stop growth hormone, sometimes we reinstitute it, of course, if they are doing better. It's not a must. It's not a must. It's a little bit a safety stuff, because we know if the secondary hyperthyroidism is very high, then you can make it slipped epiphysis. This is rarely nowadays, but when I started in nephrology, we had several cases with that. It's not a must.
Okay, so thank you. One more question is about do we give growth hormone in a child with hypothyroidism?
Hypothyroidism.
Yes.
We will first correct hypothyroidism, which is an easy go, and then start it. Or maybe, sorry, of course, we have to check if growth is also a little bit improving with that. But usually it's a combination. Usually if a child has chronic kidney disease and it's not growing very well, we usually, hypothyroidism is not the cause for that. So the child has this in addition. So we took care of that. Of course, if the child is growing better, then we may withhold growth hormone, but usually we correct it and then start growth hormone. The demands of the body are higher for thyroid hormone if you're growing better. So that's the main reason why you check thyroid hormone levels. We know this from the patients who have a growth hormone deficiency, because sometimes they need thyroid hormone as well if they are growing better. This may demask hypothyroidism.
Thank you, Dr. Turki. Thank you, Professor Hafner. Very nice talk. And we will come to the end, but there is an announcement before the closing remarks by Dr. Khalid Al-Hassan.
Initially, I would like to thank Dieter for accepting our invitation, and always, actually, whenever I just email him that we need you to be with us in our national or GCC meetings, immediately he will say yes, of course. And we have actually the pleasure, we have him with his wife probably in 2018, and still I have the picture with him with his Saudi uniform, actually. So thank you very much, Dieter, for being with us. Thank you very much for very terrific and wonderful talks. And probably, maybe Dieter doesn't know, we have major problem actually in utilizing growth hormone in Saudi Arabia. Hopefully now, for the last 2 years, it get it much improved. Our colleagues start to prescribing growth hormone, because some of them, unfortunately, they refer the patient to endocrine, and endocrine, they have completely different visions, and even the dose is different than the dose which we use. So thank you very much for your talk. Hopefully after your talk, more and more our colleague will be enthusiasm to start the growth hormone. And hopefully next time we'll have you again as face-to-face in Saudi Arabia. So for just a talk for our, actually the attendance, it's amazing attendance. Actually, it's really putting a lot of pressures to the Saudi Society of Nephrology by all of this trust of its educational material that's conducted. Whenever we have any education, whether to be webinars or conference, we have very huge attendance. One of our conferences, we had last year 27,000 attendees. It was, of course, adult and pediatric conference. Our webinars usually around 2,000 to 5,000 attendees. Now, although it is just a pediatric conference, our pediatric is much less than the audience is less than the adult nephrology, as all we know. And mashallah, we reach almost 3,500 attendees, and they are sitting until the end late in the night. In Saudi Arabia now it's almost 10:30, so it is a little bit late actually, especially in the weekends. So thank you very much. Thank you for your trust. Thank you from my heart for your trust for all the educations that will be conducted. I would like to thank the works hands to hands with Dr. Khalid Al-Sa'ran for the last 1 year. Actually, I remember their term supposed to be actually 2 years back, or 1.5 years back, and it was postponed because of the COVID. Then I have a conversation with him, what to do. Shall we conduct it face-to-face? Shall we make it just virtual? I just support him, just go ahead, make it virtual. We have long experience in Saudi society that the attendance is marvelous actually. And alhamdulillah, thanks God, things went very smooth and very good. So thanks for all the organizing committee. Thanks for the scientific committees, all of them named one by one. I would like also to extend my thanks to all our speakers, whether the national speakers or the international speakers, our moderators. So it was like a carnivals in pediatric nephrology for the last 2 days. Lots of knowledge, lots of talk, lots of interactions. So thank you very much for all of this. So before I will give the mics to Professor Khalid Al-Sa'ran to just conclude. After he finished, then we will discuss the plans for the hosting the 9th Saudi Pediatric Nephrology Conference, and how many centers they apply to host it. Go ahead, the mics is your, Professor Khalid.
Thank you, Dr. Khalid. It really was very interesting event. I would like to take this opportunity to thank our executive administration at King Saud Medical City. I would like also to thank the Saudi Society of Nephrology and Transplantation for their logistic support. Thank you, Dr. Khalid Al-Hassan. And I would like, as Dr. Khalid mentioned, to thank the organizing and the scientific committees, the speaker, the moderator, and also thank you for our sponsor for their support. And thank you to the attendee to remain till now, 3,400 remaining till the end. Thank you very much. And I am sure there is a big number who cannot access the Zoom, because the registration is 17,000, it's around 17,000. Anyway, thank you very much, and hopefully we will see you in the near future in a scientific event in Saudi Arabia or somewhere else. Thank you very much.
يعطيك العافية. Thank you, Dr. Khalid. Yeah, I forget to say that more than 16,000 registers. You know, there is unique user, so we'll present, inshallah, all the statistics for attending, from which countries, and is it and how many in total, the unique user or multiple users, and we'll post it in the Twitter of the Saudi Society of Nephrology Transplantation. Now we'll move on to last step before we are conclude tonight. So as you know, our conference is happening, the pediatric nephrology, the Saudi Pediatric Nephrology Conference. The first conference was held in 2010 and was by initiative of Dr. Isam Al-Sabban. Great thanks to Professor Isam Al-Sabban. He started this initiative. We will not forget it at all. It is in the history. And subsequently, it's moved on from center to center across the Kingdom of Saudi Arabia. And it's been now, we agreed upon it should be happened every 2 years. So next time it will be, inshallah, 2024. Until now, I received 2 requests, actually, from the KFMC. They request to host it again, and also I received a request from the Pediatric Nephrology Department at King Saud University. So both of them, the request at the last time, just before 30 minutes. So I will be neutral. I will not move. By the way, they don't count me part of the KSU, because I'm working now in King Faisal Specialist Hospital at kidney transplant centers. So I will be neutral. I cannot move here or here. But what all we need to remember that, mashallah, the KFMC, they host, I think, the 3rd or the 4th conference that's happened for pediatric nephrology. It was marvelous, actually. Probably the KSU, they didn't host anyone until now. So maybe I will go with those who didn't host any time, so to give the chance to more. So I will hear from you. Dr. Adi is here representing KSU, and Dr. Abdul Karim, I'm not sure he's here. Dr.
عبد الكريم موجود.
عبد الكريم is here. So Abdul Karim, would you like to give the chance to KSU, or still you would like to take it? Maybe the only way to do it by بالقرعة. I don't know it in English.
Okay, thank you, Dr. Khalid. I think, you know, if our colleague in King Saud University, they would like to conduct this one and they have no chance to do it before, I don't mind, really. Even my colleagues were really willing to go ahead for it. But in case of our colleagues in King Saud University would like to go for it, we will not compete with them.
ما شاء الله يعطيكم العافية. عادي تفضل. عادي، دكتور عادي. دكتور عادي, are you nearby?
تراك ميوت.
ميوت يا عادي. Maybe he's a little bit far away. So anyway, so by this, thank you very much, Dr. Abdul Karim. We cannot forget the conference that been hosted at KFMC first time. It was one of the wonderful conferences. Still, I remember Patrick Proof, he was with us. Franz Schaefer was with us. And and I forget the third, there was a third international speaker, but that maybe the first time I met Franz Schaefer face to face also. First time I met Pat face to face. So I think with that, maybe which will be KSU, inshallah, they will host the 9th Pediatric Nephrology Conference. It will be 2024, inshallah, if we are alive, bismillah. So so congratulations for them, and you can start preparing from now to compete. Marvelous, actually, conference that's happened last 2 days. Actually, it's so difficult to compete it, but they will try, I'm sure. So thank you very much. تصبحون على خير, and good night. See you inshallah next time. Thank you very much.
السلام عليكم.
عليكم السلام ورحمة الله.